Yes.
ഗഫൂർ ഭായ്, നമുക്ക് ഒരു 5
Biju,
മിനിറ്റ്
yeah.
കഴിഞ്ഞിട്ട് ഒരു 5 മിനിറ്റ് കഴിഞ്ഞിട്ട്
Okay,
തുടങ്ങല്ലേ?
okay. Yes, sure. आइकॉटे.
Blood pressure है ज़्यादा.
Bothered about it. So this made me think about this and do something for this. അപ്പൊ ആക്ച്വലി നമ്മളെ ഗ്രൂപ്പിലുള്ള ഒരു ടോക്കിന്റെ ഭാഗമായിട്ടായിരുന്നു I just started the call center with the help of other specialists in Tirurangadi. അപ്പോൾ നമുക്ക് എന്ത് ചെയ്യാൻ പറ്റും ഈ ഒരു സിറ്റുവേഷനിൽ നമുക്ക് എന്ത് ചെയ്യാൻ പറ്റും? See, we are trying to procure all the things for the category B. We are doing a lot of things are there. We are procuring ventilators for them. We are just trying to build even temporary ICUs for them. So but nothing is being done for the 80% of the people who are sitting at home and they are jumping from one category to other, but they do not know what to do. Adana I had even a call from one of the from the ward members. She understood what is going wrong in the field connected to the doctors. So what she was saying is the doctors are just prescribing paracetamol or antibiotic for them, and they were not concerned of the public health part of it. So let me start. So when the government of Kerala started things, we had actually five tier system for managing the patients. So you all might be knowing about it. So what personally what I feel is all this planning is going to be hampered with the onset of a lot of cases in our field. So I'll come to the point. So till date, what was the eligibility for home isolation? It is asymptomatic patient or the mild cases, they were kept in for the home isolation. അവരായിരുന്നു ഈ രണ്ട് ഗ്രൂപ്പ് ആയിരുന്നു. So asymptomatic patient means who is COVID positive but who doesn't have any symptoms pertaining to ILI or SARI. So mild cases means those who are not having any signs or symptoms pertaining to hypoxia, or in a more clinical. When you classify them based on the clinical criteria, you can say that all the patients who have a SpO2 more than 94 and the respiratory rate is less than 24, all these cases, they are eligible for home isolation. So what are the basic requisites you require for home isolation in Kerala? What are the guidelines? So the patient should have a separate room with available toilet attached to it, and it should have a good cross ventilation. And the most important thing is there should be someone to take care of the patient. And as I've already told you, only the category A, the asymptomatic mild cases are kept at the home. So government has come out with a new guidelines, which is not published widely. It is available on the DHS site, which says that we have to be prepared to have this category B kind of patients and mild category C patients at home. You will be forced to manage it because all the beds in the hospitals, all the ICUs in the hospitals, all the COVID hospitals, all other category of hospitals managing COVID might be full. So we might be forced to manage all these patients at home. So the government has come out with a Kerala government has come out with a guidelines. It has come on May 1st, but it's not widely published, or it's not widely circulated anywhere. So it's been directed to the DMO, and the DMO is circulating to the government officials, government doctors. That's what I told. That's what I came to know about it. This is a very simple criteria which we use, nothing related to treatment or anything. It's just for the administrative purpose we use in India. And this similar criteria was used for managing the patients when H1N1 pandemic was there in 2009. So when a category A means there is no fever, only mild symptoms are there. In category B, if you have category A with other comorbid conditions, you call it category B. And category B also includes those above 60 years and pregnant ladies. And category, you might be knowing all the symptoms suggestive of
Biju,
severe.
have you got on mute?
Yeah.
Mute ayo.
Mute I? Illello.
ഇല്ല കേൾക്കുന്നുണ്ട്.
Anything problem undo? You're not hearing?
കേൾക്കാണ്ട്.
Audible and Biju, you are audible.
We can hear.
Yeah,
You're fine. I can hear.
I should raise my voice?
No.
No.
This is
We
okay,
can
fine.
well hear.
We can
Totally
hear you very
Some
clearly.
problem with Ashraf's.
Okay, fine. Ashraf, കേൾക്കുന്നുണ്ടോ?
Speaker അല്ലാത്തവരൊക്കെ
Ashraf?
mute ചെയ്യും.
Ashraf? Okay, fine. See, category C means all the patients who are having severe acute respiratory illness. SARI, you call it SARI. And if there is any worsening of underlying chronic conditions, or if it is not responding to the usual modalities of treatment, you have to consider a patient. You have to suspect a patient to have a category C disease. And you all might be knowing about the red flag signs related to COVID infection. I'll be talking about it more. And I think Rajesh will be touching on all these things. So this is the criteria which is very important, pertaining to the treatment purposes. Mild means there is no signs of hypoxia. In moderate, you have mild hypoxia, and if the SpO2 rate is level is less than 90, you call it severe. So this is the, just a minute. So this is the triage. This is the triage we use for the asymptomatic patient or mildly symptomatic patient at home. So what happens here is every day the patient is called either from the PHC or any other designated person, such as we also call the patients. IMA can also call patients. Any doctor can call the patients. The private hospitals can also call the patients. Every day we ask them whether you have any symptoms that is suggestive of red flag signs. You have to go straight to the COVID hospital. And there are other two self-monitoring methods for the patient, which the patient does himself. If he has any symptoms which is suggestive of the red flag signs, he has to call either the concerned PHC or Disha. Disha is a 24-hour control center, which is basically for managing such disasters. The number is 1056. We had the Disha during the last pandemic of H1N1. And if the patient is having a pulse oximeter, he can also monitor it. He's supposed to monitor it at least three times per day. And if the level is below 94, he has to inform the PHC. And according to the advice of the PHC doctor, the PHC doctor will get in touch with we have a control room in every district, which is called the VAR room. And the PHC doctor has to contact this number, and he'll get the availability of the beds at that point of time. And with the help of the government has come out with the ambulance service 108. They'll call the one, it's all equipped even with a, I think they have all the ICU facilities also in that. So once the PHC doctor initiates this, he'll ask the condition about the patient, and according to it, he'll refer the patient to the concerned hospital, either the COVID or the first line or the second line center. So this is the triad system which we are following till date. But that is going to change as we have to see, as I've already told you, we have to see patients beyond this asymptomatic or mildly asymptomatic patients. So these are the red flag signs you might be knowing about it. It is altered sensorium, suggestive of cerebral hypoxia, breathlessness, chest pain. Patient might have drowsiness because of hypotension. He can have hemoptysis, excessive fatigability, which is suggestive of cellular hypoxia, syncope also because of hypoxia, and palpitation. Now the government has come out with 2 criteria. That is, we are getting a freedom to keep a patient in the home isolation till he develops this red category. You need not shift the patient if he is having just breathlessness. So according to the red category, if the patient is having severe breathlessness, if he is not able to talk, if he is not able to complete a sentence, you have to consider him as a red category. If he is developing symptoms, sudden symptoms, or his symptoms are getting aggravated within a period of hours, you have to consider him as a red category and immediately shift the patient. And if the symptoms are not pertaining to any previous illness which is contributing to the breathlessness, you have to consider him as a red category. And if the patient is also having breathlessness at rest, you will also have to consider him. If the SpO2 is less than 90, you will have to consider him as a red category. Suppose if the patient is not having a pulse oximeter, which is happening over here in most of the houses. Most of the houses, it's not available because of the, it is not available. And the other thing is it's very costly for the people to afford it. So what you tell them is it's a single breath holding test. What we do it's a simple tool which anyone can perform. So what you tell the patient is to hold the breath for 30 seconds. If he is able to hold the breath for more than 25 seconds, it denotes a normal cardiopulmonary status. If he can only hold between 15 to 25 seconds, it is suggestive of yellow category. It is, you have to be careful. If he can hold breath only less than 15 seconds, not more than 15 seconds, it is one of the signs of red category, and you will have to shift the patient immediately. And the other symptoms being, if the patient is having symptoms of shock, as you all know, it could be altered sensorium, it could be cold and clammy skin. And if the patient was okay till then, and he's not able to do all the activities of daily living, he's not able to take care of himself, you consider him as a red category and he has to be shifted immediately. This is about it. Now you have a yellow category, which is little more, the symptoms are not so aggressive. You have time to plan shifting of the patient. Whereas in the case of red category, you have to do it very immediately. So the symptoms the breathing has worsened over last 24 years, and he has breathlessness on exertion. And what you do, and the patient is not responding to the usual line of management, and you have a SpO2 more than 94 at rest. The SpO2, according to the SpO2, it might be normal But after doing a walk test for 6 minutes, or you ask the patient to take 40 steps, if there is a desaturation level of difference of more than 3% from the baseline, you have to consider him as a yellow category, and he has to be shifted, but not immediately. Suppose before doing this exertion, he has a SpO2 level of 98, and after doing the 6-minute test and you find it less than 25, it shows there is a level of desaturation, and you have to shift the patient. And I've already told you, if the single breath holding test is between 15 to 25 seconds, it is slightly compromised, you have to shift the patient to the hospital. So this is the algorithm of it. So if the patient in home care comes with red flag, and if the patient is not having it, he doesn't belong to the high risk group, you can still put him in the home care, provided you can provide all these drugs. So the government recommends ivermectin in a dose of 200 microgram per kilogram body weight. It is given 3 to 5 days. And if the patient is not responding, if the patient is still having fever, cough, even after 5 days, the guidelines says to start oral steroids. It could be, I think, dexamethasone 6 milligram. It's given as 8 milligram because the equivalent of 6 is 32. So it should be 6 milligram, or prednisolone 40 milligram. It is given for a duration of 7 to 10 days. And if the patient is also having breathlessness, you can give oral anticoagulants in the above dose. If the guidelines also says that you can also start aspirin instead of the above anticoagulants. I think Ashraf might be able to give us something new about this. Before starting the anticoagulation, we have to see whether if there is any contraindications about that part. I think Dr. Ashraf will be telling us. So you have to reassess the patient. You have to reassess the patient every 12 hours. If either the yellow category is there at home, you should ensure that the patient is seen either by a doctor, by a mobile team. The mobile team can be from the government side. The mobile team can be from the private side. I think ICRA has already come out with a mobile team. So they have to see that the patient is assessed every 12 hours. It has to be seen that the patient is seen every 12 hours. If that facility is available, then only you can have those patients at home. And if a yellow category has, the patients have high risk, they belong to the high risk group, they should be immediately hospitalized. See, this red category of patients, if there is any delay on getting the ambulance or anything like that, the guidelines states that you can start oxygen for these patients at a rate of 10 to 15 liters per minute, and this is provided by the mobile team. So this is about the things we have to do in the ground level, and I think every doctor should know all these things, because a stage is set in where the hospital beds are full, the ICU beds are full, so we are forced to manage patients at home. So hope what I wanted to convey to you is clear. Thank you. Over to Gafur.
Okay, Biju, thank you.
Biju,
And,
can I have a question?
yeah, sure.
Because I don't know the system. How do you, before you advise home isolation, how do you diagnose a patient?
Pardon me? About
how are you
what
going to
COVID?
die? Yes, because
No.
you
They are already, see, the patients, they are already tested at home. And if the patient belongs to a high risk category, you need not test the patient. You can assume that he is having COVID. There is no harm in.
So the start in the isolation starting, you, based on the patient's symptoms, you are or do you have to have a confirmation before you categorize him to various categories, high risk, low risk, or medium risk?
Sudhakaran, see, what government says that you have to ensure that the patient is tested at least once. But there is also a algorithm which I saw that if the patient is asymptomatic, if it is a suspect case, and if it is asymptomatic, you need not test the patient. But if the patient develops either mild or severe symptoms, you have to initially do a RAT for him. And if it is negative, you have to do a RT-PCR for him. If still negative, you have to treat him as per the guidelines.
Okay, Biju, and the question is, if somebody says they got some symptoms, which is and then you would, first of all, you then say, okay, somebody is coming to your house to do a test, rat test, or is it
No. You have to go to the hospital. You have to go to the hospitals. Only very few hospitals and the private labs are given permission to do it. The permission is given by the ICMR.
Sorry, about a symptom a patient will go to the one of the centers to have it tested, and what and the test is informed straight away, or he goes back to the house to isolate, or what?
No. See, if it is a rat test, you get the results immediately. But in the case of RT-PCR, it takes at least 2 to 3 days to get a result from a government system, 24 hours from a private system.
Actually, as I said, the question is because I do not know how it works, because that's why I'm asking this question. So
logically, what I feel is, see, any patient is coming with ILI symptoms. See, even if you do the test, it's not 100%. You don't get 100% positivity. You can consider this as a as COVID if he is having any high risk contact. Even if you don't have a high risk contact, there is already a community spread is there. You can very well treat him as a COVID. There is not going to be any harm. See, if you want, you can also add oseltamivir if you have any doubt. It's a very safe drug. See, you have to differentiate between. These are the two things you have to differentiate. Asymptomatic, if the patient is asymptomatic, you can keep the patient at home. If he develops symptoms, you can test it. Even if the patient is not developing symptoms, on the 7th day, you can do a test. On the 10th day, if he's having no symptoms, he can be discharged. He can get out from the isolation and he can go for a quarantine for another 17 days. So the total of 17 days, the patient is to be at home. If it is a high risk or low risk primary contact, for a secondary contact, he doesn't have to stay at home. He doesn't have to be in quarantine. That is, hope this is clear for you. Sudhakaran?
It was that's clear. It was just to find out how the flow chart actually starts, right? Before you categorize him or advise him to isolations, home, or with the category. So you have to make the diagnosis clear. So that is what I was thinking. Because what I was trying to understand is, when the pandemic started here first, when in last year, the way it was rolled out here was, okay, if you have this type of symptoms, there's no point in testing.
Yeah.
you have it. Okay, so
Yeah.
there was no. So when I all had COVID, we never was tested. We just
Yeah.
had the classical symptoms. We were at home. Okay,
Yeah.
so that is the point I was trying to understand. So
Yeah.
for to make the recommendation that you are asymptomatic cases, you are that. So for that, whether you are proving it with the test or assuming it, this is COVID based on your symptoms. That is the difference, because
See,
now the
Sudharan.
situation here
Yeah.
has changed, because everybody is getting tested at a flat center, so you can drive and have the test on the day of the symptoms. So we know whether you have it or not straight away. So that was the
Yeah.
that was what I was asking. So once you know it, then I understood what the strategy is. But getting into to one of those groups, whether you are basing it on symptoms alone or is it basing it on a proof, was what I was trying to understand. Anyway,
See, a
that's
case. See, a case means.
sorry.
Okay. See,
Hello.
what happened during H1N1 pandemic? See, we have to follow what the government guidelines says. We cannot go beyond that. See, a patient is having fever. You know it, that patient is having either COVID based on the symptomatology, based on the epidemiological characters,
Correct.
and if the patient, the family members might be having it. But according to our criteria, the patient should go to to a facility. He has to get tested.
Yeah.
While he goes to the center for getting tested, he might be using an auto rickshaw. He might give it to that person, and the lab might be totally crowded. So actually, there is no point in the patient knowing his status. So we have to assume and treat him actually. But as per the guidelines, we have to follow it. And the guideline says that if the patient is symptomatic or mildly symptomatic, severely symptomatic, he has to know his profile, COVID profile. That is very important. First, he has to do antigen test. It is negative. That is the algorithm for it. I think Rajesh might.
Yeah.
Okay, Biju.
Yeah.
Okay, then.
Understood that. That's right.
Biju, let me interfere.
Yeah.
Okay, we have to move on to the next session.
Yeah.
We have time left, and if you have time left, we'll discuss at the end.
ഞാൻ സൈത്താണ് ഒരു ചെറിയൊരു ഇത് പറഞ്ഞോട്ടെ.
Yes, Sajid.
Come on.
Okay. ഈ ബിജു പറഞ്ഞ ഇറ്റ് വാസ് എൻ എക്സലന്റ് പ്രസന്റേഷൻ. ബിജു പറഞ്ഞാൽ ഈ ബ്രെത്ത് ഹോൾഡിംഗ് പറഞ്ഞു. ആക്ച്വലി ഈ ബ്രെത്ത് ഹോൾഡിങ്ങിന്റെ ഹിസ്റ്ററി വന്നിരിക്കുന്നത് അനസ്തീഷ്യ എന്നാണ്. ഇറ്റ് വാസ് ആക്ച്വലി കോൾഡ് ദ റോത്രാസ് ബ്രെത്ത് ഹോൾഡിംഗ് ടെസ്റ്റ്. നമുക്ക് ബ്രെത്ത് ഹോൾഡ് ചെയ്തിട്ട് 25 സെക്കൻഡ് പിടിക്കുകയാണെന്നുണ്ടെങ്കിൽ that is called your cardiopulmonary reserve is good. അതെന്നാണ് ഇപ്പൊ ഈ സാധനം വന്നിരിക്കുന്നത്. ഇറ്റ് വാസ് ആക്ച്വലി ഡിവൈസ്ഡ് ബൈ വൺ പേഴ്സൺ കോൾഡ് റോത്തറ. അപ്പൊ ഈ റോത്തറാസ് ബ്രെത്ത് ഹോൾഡിംഗ് ടെസ്റ്റ് ആണ് ഇപ്പൊ ഇവർ ഈ എംപ്ലോയ് ചെയ്തിരിക്കുന്നത്. ആൻഡ് അതിന്റെ ക്ലാസിഫിക്കേഷൻ ഒക്കെ അതേപോലെ തന്നെയാണ്. വാട്ട് എവർ സെഡ് ആൻഡ് ഡൺ. അപ്പൊ ഞാൻ ജസ്റ്റ് ചിപ്പ് ഇറ്റ്, ദാറ്റ്സ് ഓൾ. പിന്നെ ഈ സുധാകരന്റെ കാര്യം പറഞ്ഞപ്പോ, ഈ ഇംഗ്ലണ്ടിൽ എല്ലാവർക്കും പഠിച്ച ആൾക്കാരാണ്. അപ്പൊ അവർക്ക് ഹോം ഐസൊലേഷൻ ഇതൊക്കെ നമുക്കവിടെ വിവരമില്ലാത്ത ആൾക്കാരാണ്. അപ്പൊ നമ്മളെല്ലാവരും ടെസ്റ്റ് ചെയ്തേ പറ്റൂ. ദ ഓൺലി തിങ് ഐ വാണ്ട് ടു പുട്ട് ഇറ്റ്. ഓക്കെ, please carry on.
So next session is by Rajesh. Mustafa is there?
Mustafa.
Yes, I'm very much here.
Mustafa.
Okay.
Carry on, Rajesh.
The session Rajesh and Mustafa.
Oh.
Carry.
Mustafa can guide the session. Mustafa can
let Rajesh start the session, and if needed,
introductory comments or anything. Okay, then
Hello?
Rajesh.
Please, Rajesh, please.
Rajesh, starting.
രാജേഷ് നേരത്തെ സ്ക്രീൻ ഷെയർ ചെയ്തിരുന്നല്ലോ. രാജേഷ് പോയോ? രാജേഷ്
ഉണ്ടായിരുന്നല്ലോ. He was just around. സ്ക്രീൻ ഷെയർ കാണുന്നില്ലല്ലോ. You have to stop sharing. Biju stop ചെയ്തോ ഷെയറിംഗ്?
ഞാൻ സ്റ്റോപ്പ് ചെയ്തല്ലോ.
Okay. Now it is up to Rajesh. Where is he?
രാജേഷ് ഒന്ന്
He was just
അല്ല
around.
മൂപ്പര് ഷെയർ ചെയ്തിരുന്നു മൂപ്പര്.
I don't know. Maybe.
Rajesh കാണുന്നില്ല ലിസ്റ്റിൽ.
Anyway, Biju, very good presentation.
Thank you. രാജേഷ് വന്നു.
Yeah.
രാജേഷ് മ്യൂട്ടാണ്. രാജേഷ്
ഉണ്ടോ? പക്ഷേ I can't see him.
ഇല്ല, ലെഫ്റ്റ് ആയിരുന്നു, ഇപ്പൊ വന്നു.
Yeah. He is there. I can see.
Yes, Rajesh.
എന്റെ സ്ക്രീനിൽ കാണാൻ പറ്റുന്നുണ്ടോ?
Yes.
സ്ക്രീൻ ഷെയർ ഇല്ല.
എന്റെ വിൻഡോയില് കാണുന്നില്ല, അതാണ് ചെറിയ പ്രശ്നം.
രാജേഷിനെ കാണാൻ പറ്റുന്നില്ല. രാജേഷിനെ കാണുന്നുണ്ട്, സ്ക്രീൻ ഷെയർ കാണുന്നില്ല.
സ്ക്രീൻ ഷെയർ ഇപ്പൊ വന്നിരുന്നു രാജേഷ്.
നേരത്തെ വന്നിരുന്നു. ബിഫോർ യു ലെഫ്റ്റ്.
വന്നു. ശരി.
വന്നില്ല.
എനിക്ക് you want to
right.
Yeah, it's good.
വന്നു. Very good.
ഒരു തമാശ പറഞ്ഞിട്ട് രാജേഷിന്റെ കയ്യിലെന്താ കൂടോത്രം ഉണ്ട്, ഇടത്തെ കയ്യില്.
എന്താണ്? ഇടത്തെ കയ്യില് കൂടോത്രം ഇല്ല, ഇടത്തെ കയ്യില് സ്റ്റാർട്ട് ചെയ്യുന്നതിന് മുമ്പ് ജസ്റ്റ് ഒരു ക്ലാരിഫിക്കേഷൻ സുധാകരൻ ചോദിച്ചതിന്. അതായത് ഇപ്പോഴത്തെ ഒരു സിറ്റുവേഷനിൽ നമ്മൾ ഈ പേഷ്യന്റിനെ വീട്ടിൽ നിന്ന് തന്നെ ട്രീറ്റ് ചെയ്യുന്ന ഒരു സ്റ്റേജ് എത്തിയിട്ടില്ല. all patients actually go to COVID triage. If a patient college once the patient comes, he will be taken to something called the triage 2. Triage 1 is for the non-COVID. Triage 2 is for COVID. Once the patient reaches there, he will be categorized, he will be graded, and his history, everything will be taken. And after that, we will tell the patient whether he needs admission, whether he has to be sent to a COVID first line treatment center or second line treatment center. Some patients may be sent home also. So right now, at least in Calicut, we have not reached that stage where we need to telephonically triage the patient. Right now, all patients are actually going to some hospital where he will be meeting some doctor. And as Biju said, there may be some pitfalls because some people may not be testing the patient. Otherwise, majority of patients, if they are tested, they will be registered in the COVID portal. After that, they will be getting a RT-PCR or RAT, and depending upon that, the patient's clinical situation, they will be treated. Coming to my own topic, ഇതായിട്ടാണ് പറയുന്നത്. അതായത് I am not the expert. I have a few patients, COVID patients under me, under treatment in college. All of them are with ortho problems. I'm not directly involved with the medical management of these patients. Anyway, because Biju insisted, I'm just presenting. So first thing we need to do is we have to look at the table of contents. So basically, I will be talking about the definition of cases. Second is how to categorize the patient. Third is grading. Then most importantly, how to identify the high-risk patients. And after that, how to treat different category of patients. And we will be just briefly going through different drugs that is used in the treatment of COVID-19. So definition of patients, there can be three types of patient. One is a suspect patient, second is a probable COVID case, and third is a confirmed case. Suspect means anybody who is having a symptom which is suggestive of COVID. Second is probable case, that means a suspect patient who has had a test, but the diagnosis not confirmed, but clinical symptoms are correlating with the COVID diagnosis. Then that is a probable case. And third is confirmed case, means somebody who is having a lab confirmed case, irrespective of symptoms, whether the patient is asymptomatic or symptomatic. If the lab confirms that patient is having COVID, it is confirmed as a case of COVID disease. Where will you suspect COVID disease? So right now, any patient who is having a influenza-like illness, any patient who is having upper respiratory tract infection, and as we are in a phase of community transmission, any patient who is having fever also, we should consider the diagnosis of COVID. Other situations where you have to suspect COVID diseases, anybody who comes with a vascular occlusion, something like a stroke, something like a multivessel stroke or acute myocardial infarction, you have to suspect COVID. In addition, any patient who is complaining of anosmia, any patient, especially for ophthalmologists, if they are coming with conjunctivitis, or a general practitioner where the patient is coming with conjunctivitis, right now we have to suspect COVID disease as per the guidelines. Then any patient who is presenting with inflammatory symptoms. Then lastly, any patient who is presenting with either myelitis or encephalitis. All these right now can be presentations of COVID disease. So in addition to respiratory symptoms, we have to suspect COVID in all these patients. Anybody with myocardial infection, anybody with stroke, anybody with inflammatory syndromes, anybody with encephalomyelitis, you have to suspect COVID disease. Any patient, when he comes in contact with the healthcare system, that patient should be categorized into A, B, and C. And each of this group should be risk stratified into mild, moderate, and severe. I will come to the details in the coming slides. The categorization depends upon the symptoms and the presence of comorbidities and the presence of red flags. So basically, it is depending upon the symptoms, comorbidities, and the red flags. Risk stratification depends upon the presence or absence of breathlessness and hypoxia. So categories are based on comorbidities, and they are also depending on the presence of red flags. So there can be three categories. Category A means somebody who is having symptoms, but he has only mild symptoms. So in addition to respiratory tract infection, patient may be presenting with only anosmia, or the patient may present with diarrhea also. Category B means anybody with the age more than 60 years. And anybody, any pregnant woman, that is again category B. Anybody with a medical comorbidity, anybody on immunosuppressants, and if there are mild to moderate to severe symptoms also, that should be considered as category B. And one thing to remember is any patient who is having fever, automatically he becomes a category B, because in category A, patient doesn't have any fever. And category A and category B, we should do a reassessment of the patient's category every 24 to 48 hours, because some patients may progress to have severe disease even in this category of patients. Category C, it can either be adult or child with red flag symptoms. In adults, it may be respiratory symptoms, chest pain, or as Biju said, it may be drowsiness, falling blood pressure, something like that. And in children, it may be high or persistent fever, inability to feed, and very importantly, convulsion, and lastly, respiratory distress. And if the patient is having some chronic condition, something like diabetes, and if the patient is having worsening of the underlying chronic condition, that also is considered as chronic category C. So in addition to red flag signs, anybody who is having worsening of the underlying clinical chronic condition, that should be considered as category C. And depending upon the categorization, in Kerala, we treat the patients in 5 different setups. One is any patient who is asymptomatic without any red flag signs, they will be advised only home care and isolation. And anybody who doesn't have any facility for home isolation, there are different panchayats have opened domiciliary care centers, and this will be usually manned by volunteers. So patients can be taken to such centers. And if the patient is having a category A, if the patient prefers, he can be sent to a COVID first line treatment center. Anybody with category B, he will be treated at COVID second line treatment center. And anybody with category C should ideally be treated at designated COVID hospital. Next thing we have to do is we have to do the grading. So this is depending upon the presence or absence of breathlessness and the hypoxia. So mild means patient doesn't have any dyspnea and patient has no hypoxia. Moderate means the SpO2 is between 90 to 94 and the respiratory rate is between 24 to 30 per minute. And in addition, patient should be having fever, cough, and dyspnea. Mild dyspnea, but on pulse oximetry, patient is not having severe hypoxia. In children, depending upon the age, the respiratory rate may be different. So in a neonate, it can be up to 60. In a infant, it can be between up to about 50. And between 1 to 5 years, it is up to 40. And more than 5 years, if the respiratory rate is more than 24, again, it is considered as moderate disease. So all these SpO2 I'm talking about is based on room app. So if the patient is having mild hypoxia, it is moderate disease. Severe grade, in adults, it means pneumonia. So any patient, adult patient with pneumonia where the SpO2 is less than 90%, or if the respiratory rate is more than 30, and if the patient is having respiratory distress, that patient is considered as a severe grade. In children, these are the different features of severe disease. Something like central cyanosis, or if the patient is having SpO2 less than 90 degree. And as I said earlier, inability to breathe, respiratory distress, lethargy, convulsion, all these are considered as severe disease. Next is identification of the high-risk patients. So this depends upon either the presence or absence of comorbidities. Second is by clinical assessment, and third is by lab values. So high-risk patient, anybody who is more than 65 years of age, anybody who is having a BMI of more than 30, automatically they are high-risk patients. And anybody with an uncontrolled diabetes and different medical comorbidities, they are also considered as high-risk patient. In addition, anybody who is on immunosuppressive agents or steroids, these patients are also considered as high-risk patients, in addition to HIV patients. And what about clinical assessment? So this can be either pulse rate more than 125, respiratory rate more than 24. Then if the BP is too low, if the patient is having altered sensorium, if the SpO2 is less than 94, all these things are considered as high-risk patients. High risk, depending upon the lab values, it can either be inflammatory mediators, so Sangeetha will be talking about that. And in addition, one important finding that is suggestive of severe disease due to severe virus replication is lymphopenia. So anybody who is having an absolute lymphocyte count of less than 800, or if the neutrophil lymphocyte ratio is less than 3.13, these patients are also high-risk patients. And one more category is there, that is the critical case. So anybody with respiratory failure, shock, or multi-organ failure that needs ICU admission, these cases are defined as critical cases. The treatment depends upon the category and the grade. So General guidelines are, one is in all patients before confirming COVID, we have to rule out influenza and bacterial pneumonia. And after that, the patients are categorized to A, B, and C. Then, as I said earlier, you have to do a risk stratification. And depending upon the category, we have to send the patient to different tiers of the treatment system. And in category A and B, we have to reassess the patient every 24 to 48 hours. And it is preferable to avoid all NSAIDs other than paracetamol. And in indicated patients, we have to do a RT-PCR or RAT to confirm the diagnosis. And if the patient is having an influenza-like disease, if there is any delay in getting the result, then it is better to start the patient on Centavir till the RT-PCR reports are available. One important thing to remember is all these patients with COVID, if they are having fever, it is usually common to have an extended duration of symptoms. Patient may be symptomatic for up to 5 days. And those patients who are on inhalational steroids, this is one general principle, you can continue these steroids, and antibiotics are not indicated unless there is a strong suspicion of secondary bacterial infection. And if there is any suspicion, you have to start the patient on broad spectrum antibiotics. And if the patient symptoms doesn't improve with antibiotics, then we have to suspect COVID-associated pulmonary aspergillosis or the black fungus infection, mucormycosis. Different patients will be, the drugs patient will be asking the doubt what to do. So earlier there was a controversy whether to continue the AC inhibitors. So now the present recommendation is if the patient is on AC inhibitors, we should continue the AC inhibitors. And if the patient is already on NSAID, right now there is no clear recommendation to stop the NSAID from different health organizations. And if the patient is on statin, aspirin, antiplatelets, it is better to continue all these drugs. But one important thing to consider stopping is immunomodulatory drugs because they may be associated with severe disease. So depending upon the individual case, we have to decide whether to continue or not. So as far as previous drugs are concerned, the immunomodulatory drugs is the only drug that needs to be stopped as per the guidelines that is available right now. There are different lab investigations that needs to be done when the patient is admitted. And all patients, if indicated, we have to consider imaging also. And depending upon the clinical situation, we have to consider inflammatory mediators, blood culture. And if there is any doubt, we have to do a TROP-I also. And in some patients, there may be worsening. In that situation, if the diagnosis not confirmed, then you can reach a diagnosis by doing a high resolution CT because the findings on the CT is specific, almost specific for the diagnosis of COVID diagnosis. And if the patient is worsening, we have to repeat all the lab investigations. And in immunocompromised patients, we have to do investigations to rule out opportunities in the infections also. Coming to treatment of different categories. In category A, treatment is basically only symptomatic treatment only. And we have to reassess the patient every 24 to 48 hours. And we have to monitor the patient for any dyspnea, hypoxia, fever, high-grade fever, severe cough, and all red flag signs. And it is preferable to do an exertional desaturation test. And if the patient is having a fall of SpO2 below 94%, then it is better to get a consultation from the respective specialty. What is exertional desaturation test? So one important thing to remember is if the patient's PaO2 is already less than 94, then it is better don't do the exertional desaturation test because the patient will worsen. When you consider the exertional desaturation test, first you have to measure the baseline. And after that, if the patient is having a fall of more than 3% from the baseline after walking for 6 minutes or taking 40 steps, then you should be considering the patient as high risk. And in this situation, we have to consider initiation of steroids. So basically this should be done in all clinically stable patients in home care. So it should be done at least once in a day. Treatment of category B, again, the treatment is symptomatic. Again, you have to do the reassessment and monitoring. And one drug that is advised as per the Kerala guidelines is ivermectin, that is given once in a day. It is actually slightly controversial because all the WHO and the different recommendations from foreign countries actually advise against the use of ivermectin. But in India, ICMR and the Kerala guidelines actually give ivermectin as one treatment. Another drug we have considered in category B is inhalational budesonide. So this can be given 800 mcg twice a day if the symptoms persist more than 5 days of onset. Coming to category C. So category C, there are 3 grades. One is mild, second is moderate, and third is severe. So treatment is different for each category C, mild, moderate, and severe. So in mild, we can advise favipiravir. Again, this is slightly controversial because not many scientific data is available for treatment with favipiravir, and it can either be favipiravir or again the patient can be put on ivermectin, and again we can consider budesonide also if the fever is persisting more than 5 days. Category C basically means anybody with a respiratory rate between category C moderate means anybody who is having a respiratory rate more than 24 but less than 30, and the SpO2 is between 91 to 94, and in this situation we have to put the patient on steroids. So basically the difference between category C moderate and category C severe is the dose of the steroid. Here the dose is slightly less when compared to the severe category C severe disease. So it can either be methylprednisolone or it may be dexamethasone. In addition, we have to put the patient on anticoagulation also. And oxygen also will be needed in these patients. Category C severe means the respiratory rate is more than 30, SpO2 is less than 90, and these patients should be put on high-dose steroids. And in addition, patients should be given anticoagulation and oxygen therapy. What are the different drugs? So specific treatment, one is steroid. So this will be indicated in all those patients who need oxygen support. This can be given by giving dexamethasone, either oral or IV, 6 milligram per day for 10 days. We can use other agents also if it is not available. And all these patients, we have to monitor the patient for hyperglycemia and secondary infections. There is some strong data which suggests that putting the patients on that need oxygen treatment on steroids, it actually reduces the mortality and reduces the need for ventilation. But one important thing to remember is if the patient is having only mild COVID disease, if you put the patient on steroids, that will lead to immunocompromise. It can increase the virus replication. And in addition, patient may develop secondary infections also. So if the steroids are given in mild COVID disease, it can actually lead to higher mortality. So steroid is a double-edged weapon. So you have to use it wisely. So you have to use it only in those patients who are having moderate to severe disease, only on those patients who need oxygen. We are getting, India actually is having almost an epidemic of mucormycosis. And in Gujarat and Bombay, there are a lot of cases being reported with mucormycosis. So all these patients are either diabetics or those on steroids, either self-treatment or a wrong treatment being given to mild COVID disease. Another important drug that has clear benefit in treatment is remdesivir. So this is again indicated only in category C patients with moderate or severe disease who require supplemental oxygen. And in addition, it should be started within 10 days of onset of symptom. Patient should not be having any renal or hepatic dysfunction, but this is not an absolute contraindication. The recommended dose is 200 milligrams on the first day IV, followed by 100 milligrams daily for next 5 days. It is a nucleotide analog, and right now it is the only specific drug, antiviral drug, that is approved fully in the treatment of COVID-19. It actually doesn't reduce the mortality or the need for the progression to severe disease, but what has been found is it reduces the time for recovery. So it should be used only in patients who need supplementary oxygen. And if the patient is having a moderate to severe renal impairment, it should not be ideally be used. And if the patient is having a severe elevation of alanine transaminase, or again ALT, again it is contraindicated. And one important thing to remember is it should not be used along with HCQS. Another drug that is associated with benefit in severe disease is tocilizumab. So this is a IL-6 blocker, and it is uses associated with a mortality benefit. But there are clear contraindications. One is uncontrolled serious infection other than COVID-19. Any patients who is having severe lymphopenia, anybody who is having thrombocytopenia, anybody who is having severe elevation of liver enzymes, and if there is an elevated risk of GI perforation also, tocilizumab is contraindicated. It should be given only those patients who meet all the criteria. One is he should be having a severe disease. There should be a significantly elevated inflammatory markers, and patients should be already on steroids without any improvement, and patients should not be having any other infection. In this situation, we can give a single dose of tocilizumab. Maximum dose is 800 milligrams. And some patients, if there is no improvement, it can be repeated after one more dose can be given after 12 hours. All these patients, you have to monitor the LFT, neutrophils, and the platelet count. Convalescent plasma, it is generally now not being promoted. And if at all it is being used, it can be used only in early patients with moderate disease, and the onset of disease should be within 7 days. And the donor plasma should be having a high titer, and usual dose is about 200 ml, that is given over more than 2 hours. And it is not recommended in patients who are on mechanical ventilation. Favipiravir again is being used, and it's a RNA polymerase inhibitor, and it is used only in mild disease. And there are some trials that is done in Russia and China, which has given some benefit. But another study that was done from Iran did not find any benefit with use of favipiravir. One salient feature of severe COVID is defective production of interferons. So those patients who have severe disease, they have complement disease, they have autoantibodies. So interferon 1 beta is now being recommended as an inhalation. And recently, Zydus Cadila has got an approval from the government of India for use. Ivermectin, it should not be used in pregnancy. It is not recommended in children. And it should not be used along with azithromycin. Anticoagulation, I think I can skip because Ashraf will be dealing with it. But only thing I would like to highlight is all patients who are admitted, they should be given VTE prophylaxis unless there is a clear-cut contraindication. And if the patient is already having a confirmed DVT, you should not use any stockings or other mechanical devices. Recent advances, I just put a slide because there is one website from the Milken Institute which has listed all these drugs under different categories. They actually have hundreds of molecules and drugs that is under investigation. So basically, they have classified all these into monoclonal and other types of antibodies, specific different types of antiviral drugs. And they have listed under cell-based therapies, different devices, RNA-based treatments, DNA-based treatments and repurposed molecules also. So all these treatments are only in the experimental stage. So to conclude, COVID-19 should be suspected in all patients with fever, upper respiratory tract infection, those with muscular disease like vascular occlusion, those with encephalomyelitis, and those who present with inflammatory diseases. Each and every case should be categorized into A, B, and C depending upon the presence of high red flag signs and the comorbidities. And depending upon the presence or absence of hypoxia and breathlessness, they should be graded. And depending upon the clinical features, lab findings, you should be looking for high-risk signs. Those patients who are categorized as C, and some patients with category B, they may need hospitalization. And if there is hypoxia, the patient should be started on steroids. And we should be using remdesivir and tocilizumab only in specific indications. So thank you very much.
Hello, I'm Sajid. I have 3 questions. Shall I proceed?
Questions ഒക്കെ മുനീഫിനെടുത്ത് ചോദിക്കാം.
എന്താണ്?
Questions ഒക്കെ മുനീഫിനെടുത്ത് ചോദിക്കാമെന്ന് അറിയാം.
മുനീഫിന്റെ അടുത്തല്ല, നിന്റെ അടുത്ത് തന്നെയാണ്. 3 ക്വസ്റ്റ്യൻ ആണ്. ഒന്ന് നിനക്ക് കോവിഡ് വന്നു?
എനിക്ക് ഇതുവരെ സോഫാർ വന്നിട്ടില്ല, ഭാഗ്യവശാൽ.
വന്നിട്ടില്ല. വന്നു വിചാരിക്കുക. നിന്റെ റെസ്പിറേറ്ററി റേറ്റ് 25 ആണ്, സാച്ചുറേഷൻ 93 ആണ്. നീ എന്തൊക്കെ ഡ്രഗ് നീ കഴിക്കും? ഫസ്റ്റ് ക്വസ്റ്റ്യൻ. സെക്കൻഡ് ക്വസ്റ്റ്യൻ. നിന്റെ റെസ്പിറേറ്ററി റേറ്റ് 35 ആണ്, സാച്ചുറേഷൻ 85 ആണ്. നീ എന്തൊക്കെ മരുന്ന് കഴിക്കും? മൂന്നാമത്തെ ക്വസ്റ്റ്യൻ. ഡസ് ആൽക്കഹോൾ
ഒന്ന് കഴിയട്ടെ സജി, ഓരോന്നോരോന്ന് ചോദിക്കൂ, ഒന്ന് ആൻസർ ചെയ്യട്ടെ.
എന്റെ ക്വസ്റ്റ്യൻസ് മുഴുവൻ കേൾക്കട്ടെ. ഡസ് ആൽക്കഹോൾ ഹാസ് എനി ഇഫക്റ്റ് ഓൺ കോവിഡ്? ഓക്കെ, നൗ പ്ലീസ് ആൻസർ.
ഹലോ,
പ്ലീസ്.
ഒന്നാമത്തെ സിറ്റുവേഷൻ എന്ന് പറഞ്ഞു കഴിഞ്ഞാല് ഇറ്റ് ഇസ് ആക്ച്വലി എ മോഡറേറ്റ് ഡിസീസ്. അങ്ങനത്തെ സിറ്റുവേഷനിലാണെങ്കിൽ ഫസ്റ്റ് തിങ് വി ഹാവ് ടു ഡു ഇസ് വി ഹാവ് ടു സ്റ്റാർട്ട് ഓൺ steroids. So as I said, it can be an inhalation steroid. പിന്നെ രണ്ടാമത്തെ ആണെങ്കിൽ it is actually a severe hypoxia. So in that situation,
രാജേഷ്, എനിക്ക് വേണ്ടത് എന്തൊക്കെ ഡ്രഗ് നീ കഴിക്കുന്നുള്ള ഫുൾ ലിസ്റ്റ് ആണ്.
ഒന്ന് steroid.
What steroid? What is the dose?
ഹലോ,
എന്ത് steroid, എന്ത് ഡോസ്?
dexamethasone 6 milligrams per day.
What route?
രണ്ടും ആവാം, ഒന്നല്ലെങ്കിൽ പാരന്റൽ ആവാം അല്ലെങ്കിൽ ഓറൽ ആവാം.
ഓക്കെ, എനി അതർ ഡ്രഗ്സ്?
പിന്നെ രണ്ടാമതായിട്ടാണെങ്കിൽ വേണമെങ്കിൽ റെംഡെസിവിർ ആണ് കൺസിഡർ ചെയ്യാം, പക്ഷെ ഒരു ഏർലി ഓൺസെറ്റ് ആണെങ്കിൽ മാത്രം. പിന്നെ കൊടുക്കുന്നത് പാരസെറ്റമോൾ.
ഓക്കെ, എല്ലാം ഡോസ് പറയൂ, ഡോസ് പറയൂ. അല്ലാതെ എനിക്ക് വെറുതെ റെംഡെസിവിർ ഇപ്പൊ ഇന്ന് റെംഡെസിവിർ ഒഴിവാക്കിയിട്ടുണ്ട്.
റെംഡെസിവിർ ഫസ്റ്റ് ഡേ കൊടുക്കുന്നത് 200 milligrams ആണ്. അത്
ഇന്നിപ്പോ റെംഡെസിവിറിനെ ഒഴിവാക്കിയിട്ടുണ്ട്. ഇന്നത്തെ ഇതില് ഞാൻ കണ്ടത്, ടി വി വെച്ചപ്പോ കണ്ടതാണ്.
അതിന്റെ കാരണം ഞാൻ പറയുന്നില്ല, ഇല്ലാത്ത സാധനം കൊടുക്കാൻ പറ്റൂലല്ലോ എന്ന് മാത്രം പറയാം.
ഓക്കെ, എന്നാ ശരി. ഓക്കെ, അതാ എനിക്ക് വേണ്ടത്.
അപ്പൊ സാധനം ഉണ്ടെങ്കിൽ കൊടുക്കുക. അതായത് as per the data that is available, remdesivir only has a effect of reducing the duration of disease.
Yes, I agree.
Actually it is having some importance also, because we can discharge the patient as early as possible from the hospital. So that is also important. അത് ഒന്നാമത്തെ കാര്യം.
വേറെ എന്തെങ്കിലും മറ്റേ സിങ്ക്, വൈറ്റമിൻ സി എന്തെങ്കിലും കൊടുക്കണോ?
അതായത് ഈ പറഞ്ഞ കാര്യങ്ങളൊക്കെ കൊടുക്കുന്നുണ്ട്. ഇപ്പൊ സിങ്ക് കൊടുക്കുന്നുണ്ട്.
എന്തെങ്കിലും കൊടുക്കുന്ന ഗുണം ഉണ്ടോന്ന് ചോദിക്കണത്.
ഇതൊക്കെ ഒരു കാർഡടച്ച് വെടിവെക്കുക എന്നുള്ള രീതിയിൽ മാത്രം പറയാൻ പറ്റുള്ളൂ.
അപ്പൊ എന്റെ ചോദ്യങ്ങൾ സ്പെസിഫിക് ആണ്. നിങ്ങൾക്ക് അസുഖം വന്നാൽ വാട്ട് വിൽ യു ടേക്ക്?
അതിപ്പോ ക്ലിയർ ആയിട്ട് പറയുകയാണെങ്കിൽ
നാളെ ഇന്നേ വരെ നാളെ എനിക്ക് വരാം, താങ്കൾക്ക് വരാം. വാട്ട് വിൽ യു ടേക്ക് ഇസ് മൈ ക്വസ്റ്റ്യൻ.
അതിന്റെ ആൻസർ ഞാൻ പറയാം. എനിക്കൊരു റഫ് കുറെ ഇത് കൊണ്ടുവന്നു. വൈറ്റമിൻ സിയും സിങ്കിന്റെ ഒരു കോമ്പിനേഷൻ കൊണ്ടുവന്നിരുന്നു. അപ്പം ഞാനും വൈഫും ഒക്കെ കഴിച്ചിരുന്നു. പക്ഷെ എന്തുകൊണ്ടാന്നറിയില്ല, എന്റെ ലെഫ്റ്റ് റിസ്റ്റിന് അത് കഴിഞ്ഞപ്പോൾ ഭയങ്കര വേദന, രാത്രിയൊന്നും ഉറങ്ങാൻ പറ്റുന്നില്ല. പക്ഷെ ഞാനത് ഒരു ദിവസം ഈ സിങ്ക് കഴിക്കാൻ വേണ്ടി വിട്ടുപോയി. പിറ്റേ ദിവസത്തേക്ക് വേദനയില്ല. പിന്നെ ഞാൻ രണ്ടാമത് സിങ്ക് തുടങ്ങിയപ്പോൾ വീണ്ടും വേദന. അത് കഴിഞ്ഞപ്പോൾ ഞാൻ അത് കംപ്ലീറ്റ്ലി സ്റ്റോപ്പ് ചെയ്തു. ഇപ്പൊ എനിക്ക് യാതൊരു പ്രശ്നമില്ല.
യൂറിക് ആസിഡ് ആവുമോ?
യൂറിക് ആസിഡ് അങ്ങനത്തെ കാര്യമായിട്ടുള്ള പ്രശ്നങ്ങളൊന്നും എനിക്കില്ല.
അല്ല, സിങ്ക് കൊണ്ട് അത് വരുമോന്ന് ചോദിച്ചത്. ഒരു ഐസൊലേറ്റഡ് ജോയിന്റ് ഇൻവോൾവ്മെന്റ്
അറിഞ്ഞൂടായിരിക്കും. ഇപ്പൊ എന്തായാലും ഞാൻ നിർത്തി കഴിഞ്ഞപ്പോ എനിക്കത് കംപ്ലീറ്റ് ആയിട്ട് സബ്സൈഡ് ചെയ്തു. എനിക്ക് പ്രത്യേകിച്ച് വേറെ സിംറ്റംസ് ഒന്നും ഉണ്ടായിട്ടില്ല. അപ്പം ഞാൻ ഏതായാലും ഇപ്പൊ കഴിക്കുന്നില്ല. നിങ്ങൾ അതിന്റെ അടുത്ത് സ്പെസിഫിക് ആയിട്ട് നിങ്ങൾ എന്ത് കഴിക്കും എന്ന് പറഞ്ഞുകൊണ്ടാണ് ഞാൻ പറഞ്ഞത്. പക്ഷെ വരികയാണെങ്കിൽ എന്തായാലും ഈ പറഞ്ഞ ഡ്രഗുകളൊക്കെ കഴിക്കേണ്ടതായിട്ട് വരാം. അപ്പം ഐ വിൽ ഗിവ് ദി മൻസൂർ എന്താണ് ഒരു പ്ലീസ് ഷാർ ദി സ്ലൈഡ് എന്ന് പറഞ്ഞൊരു.
അല്ല, വേറെ ആർക്കെങ്കിലും പറയാണ്ടോ? എന്റെ ചോദിക്കുന്നത്, രാജേഷിനെ ഇത് ട്രീറ്റ് ചെയ്തിട്ടുള്ള പരിചയമില്ലാക്കിയോളൂ. വേറെ ട്രീറ്റ് ചെയ്ത പരിചയമുള്ള ആൾക്കാർ ആരെങ്കിലും ഉണ്ടോ ഞാൻ ചോദിക്കണേ. എനിബഡി ഹാസ് ട്രീറ്റഡ്. എന്തൊക്കെ പാത്രം വരുന്ന ശബ്ദം കേൾക്കുന്നുണ്ട്.
അതാരും കോവിഡ് ട്രീറ്റ് ചെയ്യാവുന്ന ശബ്ദമാണോ കേട്ടത്?
അല്ല, പാത്രം വരുന്ന ശബ്ദം കേൾക്കുന്നത്.
അത് നമ്മുടെ സജിത്, originally when there was patients in the ward for with COVID.
Sudhakaran, please switch on your video so that we can see you.
ഇപ്പോൾ ആരൊക്കെ പാത്രം വീഴുന്നത്?
അതെ, ഒരു മിനിറ്റ്. Just the question is, Saji, the problem, the various list of medicines that's been given by Rajesh, there is only evidence based only for steroid, remdesivir, and some tocilizumab in very specific indications. You just you're giving it with absolutely no clear evidence.
അല്ല, ഇന്നിപ്പോ മറ്റേ നമ്മ റെംഡെസിവിർ വരെ ഇന്ത്യയുടെ നിന്ന് മാറ്റിയിട്ടുണ്ട്.
I'm just telling you my experience when the people were we were put in the COVID ward.
Tocilizumab cost 40,000 a vial.
Correct. I know. I'm not.
2 ഡോസ് കൊടുക്കുന്നുള്ളൂ. ഇപ്പൊ 1 ഡോസ് കൊടുത്തിട്ട് ആവശ്യം ഉണ്ടെങ്കിൽ മാത്രമേ, ഗുണം ഉണ്ടെങ്കിൽ മാത്രമേ രണ്ടാമത്തെ കൊടുക്കുന്നുള്ളൂ.
I know what I'm trying to say is the ivermectin, various antivirals, all has been dished out, but the amount of evidence to support those things is very small, as Rajesh was clearly telling. So do we have to give it or not is a question. My own view is it is probably not needed. Dexamethasone, remdesivir, and in that specific indications, and tocilizumab when in ITU situations were all we were giving at that time. We were not giving anything different. The anticoagulation was our mainstay of treatment. Really, anticoagulation was the mainstay of treatment because it is
okay. Let Ashraf finish. Okay.
Once Ashraf's talk is there will be some questions there.
Okay, please. Okay, please.
Yeah. So that is my view on. But now I don't treat COVID patients because at the moment the number of cases are down, so we are being withdrawn from COVID duty to our normal care. So we don't treat COVID patients. So at that time, every other doctor, whether you are a neurologist or a neurosurgeon, you are all only treating COVID patients in the ward. We're just doing ward rounds with COVID patients. That's what we were doing. And at that time, I could not see any of these drugs just being used, because most of the there were lots of trials going on. So tocilizumab was part of the trial. The recovery trial that just been published doesn't say plasma is of any use. So plasma was being used, and then so it was all based on trials. That and the first one that came out very positive was dexamethasone, and the other steroids. Actually, the evidence, I don't know whether there is there or not with methylpred and the hydrocortisone. I may be mistaken.
Sudhakaran, see why
Yes.
there is a difference of dose between the mild and moderate and severe. Why is the difference?
What difference?
Difference in the dose of steroids in moderate and severe. Why is it like that?
And then the standard dose was 8 milligrams per day. That's it.
Achha.
So
No,
8 milligrams.
Sudhar, is it 6 milligrams per day?
No,
It should be
here
6,
it was
no?
8. Here it was 8 milligrams per day.
No, in India it's 6 milligrams per year.
I don't know that but it was 8 milligrams per day. Other they will the ones they cross a threshold, that means they are moderate, requiring a lot of oxygen.
What I see is 6 milligrams TAD is being given here. Most of the cases.
It is actually single dose.
It is actually single dose. That's what we were giving.
Yeah.
I am only just telling you what they
are
experience.
giving 6 milligrams TAD.
That has
got no trial basis. But
that is what
only 6 milligram. 6 milligram OD, or in severe case 8 milligram OD.
ഇവിടെ കൊടുക്കുന്ന കാലിക്കറ്റ് കൊടുക്കുന്ന 0.7 milligram per kilogram body weight, the maximum of 6 milligram, or 1 milligram per kilogram body weight, maximum of 7 milligram. So it is something between 6 and 8, but 1 day.
നമുക്ക് നെക്സ്റ്റ് സ്പീക്കറിലേക്ക് പോവാം. ഇത് 9:30 ആയി. ലാസ്റ്റ് ക്വസ്റ്റ്യൻസ് ഒക്കെ ലാസ്റ്റ് എടുക്കാം അല്ലേ?
ഒരു ക്വസ്റ്റ്യൻ കൂടി. Okay. Is there one laboratory test which will guide you to the prognostic indicator? Patient നന്നാവുകയാണ് ചീത്തയാവുകയാണെന്ന് പറഞ്ഞാൽ ഏതെങ്കിലും ഒറ്റ laboratory test ഉണ്ടോ രാജേഷിനോട്?
Absolute lymphocyte count.
Please elaborate.
I think
what we thought was a D-dimer test.
നമുക്കിത് കഴിഞ്ഞിട്ട് ലാസ്റ്റ് ചെയ്യാലോ അല്ലെ? ഇല്ലെങ്കിൽ എല്ലാരും പോയി പോവാ. 9:30 ആയി. ലാസ്റ്റ് ഡിസ്കഷൻ വെക്കാം.
ശരി. Okay.
Mustafa?
Yeah.
Mustafa?
Yeah. Oh, I'm next.
Mustafa joined the session. Okay, then Munif.
Hello.
Munif.
Munif, where is Munif?
Hello, Gafur.
Mustafa, you can join the session.
I think that was an excellent coverage by Dr. Rajesh. And even though he had an initial disclaimer, he had made the presentation excellently about the medical management. And what we are following here is as per the guidelines which are issued from time to time by the government, and almost all the recommendations published in the guideline we are following. Especially now I am working at Manjeri. We had roughly 60 to 70 patients at a time in our ICU, and we used to give drugs like remdesivir and tocilizumab. Even though now due to the availability and shortage of this remdesivir and this tocilizumab were not that much used, and that is also about plasma. Plasma therapy was used extensively in the initial part, but that also now not much promoted. So thank you, Rajesh, for your excellent presentation.
Thank you, Mustafa, for the comments.
Okay, Munif is there. Munif,
Munif ഉണ്ടായിരുന്നല്ലോ.
I think.
Yes. I'm here.
Munif, you are supposed to start to open the session by Sangeetha. You have any opening remarks or something?
Okay. Good evening, everybody. I think that we are already running out of time. We are fortunate to have Dr. Sangeetha here as a speaker on immunology of COVID, because that is the most important part. And still, we are in a dilemma. What is going on with every patient? Because we see the phenotype of all the patients are different. Most of them are different. So what is deciding is probably their inflammatory cascade, which has been induced in the body. So let's hear from the speaker, our own Sangeetha.
Okay, thank you. I hope you can hear me. I'm going to try to open my screen. Okay, let me see, close this and see.
Sangeetha, we can't see your video.
Oh, you can't see my video. I'm trying to open my PowerPoint. Just give me 1 second. Slideshow. Okay, can you see anything?
No.
You still can't see? Oh, what happened? I'm not sure. I have a technical problem. 1 second.
No issue. You take your time.
Oh, can you see me now? I've tried to share screen. Can
Yeah.
you see the screen? Let me stop there. Okay.
Yeah. It has come.
Yeah, it's
All
coming
right.
now.
Okay, good.
Okay.
So
Yeah.
I'm gonna. I have a talk on cytokine storm in COVID-19. So I'm going to try to break this down into multiple parts and explain it. Forgive me if it is I don't come out clear, and just interrupt anytime, or at the end ask me any questions. Okay. So to begin, what is cytokine storm? So it's essentially there is an uncontrolled hyperinflammation that is triggered by cytokine excess. And the end result of that is that multiple organs can be involved and there is possible death. Okay. So this is the hyperinflammation stage that Rajesh mentioned in his talk, which usually happens in the later part of first week or the second week after the infection. So there is pro-inflammatory cytokines that are involved are IL-1 beta, IL-6, which is the antibody against that is the tocilizumab, and IL-8, GM-CSF, TNF-alpha, interferon gamma. The second word that you get used here a lot is chemokines. Chemokines are again a part of cytokines, and their role is to recruit cells to site. So they are involved in chemotaxis. And don't worry about the alphabet soup. There is different chemokines that is mentioned. The ones of interest are CCL2, CXCL10, CXCL8. So the names don't matter, but cytokines and chemokines are important in the hyperinflammation that we see with COVID-19. So again, what are the main laboratory abnormalities in patients with unfavorable prognosis of or progression of COVID-19? Again, Rajesh touched upon this, but I'll just briefly run through. In early infection, all your parameters are normal. You have normal leukocyte count, normal lymphocyte count, lab results are all normal. When you move on to the hyperinflammation phase, you start to see a decrease in your leukocyte count, in the peripheral leukocyte count. The lymphocyte count is decreased less than 1,500. Eosinophil count starts to drop, but your neutrophil count starts to go up. So it's usually more than 10,000. Your platelet count starts to drop down. And other inflammatory mediators start to increase, which is your IL-6, C-reactive protein, your serum ferritin goes up, your procalcitonin goes up. And as an indicator of coagulative state, you start seeing more D-dimers. So this is something, and I have based most of my talk on immune reactivity, an article that came out in January, which is some of this is from that data and some is from another article I'll show a little later. So this is a busy slide, and I'm going to break up the slide into different parts. So in the first part, I want you all to focus on this section, which is focusing on pneumocytes, okay? So pneumocytes, there are type 1 and type 2 pneumocytes in your alveoli. And here is your SARS-CoV-2 COVID-19 coming in. And look at this word pyroptosis. So we're going to look at this pneumocyte, which kind of is important in understanding how the infection actually happens. So going to that, so the viral particles infect first type 2 pneumocytes. They infect them because the antigen can attach itself to the ACE2 positive cells. That is, the pneumocytes have ACE inhibitor receptor on it, and so they can attach to that. So what happens once the infection happens is that there is proliferation and pyroptosis happens, which is essentially cell death, but it's an inflammatory form of cell death. So when the cell death happens, all of these fragments of the viral RNA is released into the cell. And so we are going to learn a couple of new words called PAMP, which is pathogen-associated molecular pattern. And that is, the parts that are released from the RNA. And then we're going to learn another word called pattern recognition receptors, or PRR. There can be toll-like receptors or retinoic acid inducible gene receptors, RLRs. So why are these important is because type 2 pneumocytes also carry toll-like receptors. So now we understand that when a pneumocyte dies, undergoes cell death, and the PAMPs are released, now these PAMPs are recognized by the toll-like receptors, and it can start infecting other cells, or it can start triggering inflammatory response. And these type 2 pneumocytes can now go on to release pro-inflammatory cytokines, because that is essentially innate immunity. So innate immunity is what triggers the release of all these pro-inflammatory cytokines. So I hope this kind of tells you that before adaptive immunity comes into play, there is innate immunity is very important, and there is a dysregulation of this innate immunity, which happens in these patients. So let's go back to that figure. And now you can kind of understand what happens here. You have your pneumocyte, there is ACE receptor, there is, this goes in, and there is death of the cell, pyroptosis, and all of these stuff is released. And then the next signaling happens through here, which is the TLR receptor. Okay, so now all of this material is in your alveoli, and then the second player comes into play in innate immunity, which is your macrophages. Okay, so we're going to look at macrophages after this, and there are two different kinds of macrophages that is important. Oops, sorry. So that is, you have your M1 macrophage and your M2 macrophages. So what is the difference between these two different kind of macrophages is what we're going to look next. And one is the M1 is more important to trigger edema of the cell lines, that side. And the M2 is important for the fibrosis that ends up happening in these patients. So these are still a part of innate immunity, and let's see their role and how the action actually happens. So what they've seen in COVID-19 patients is mostly there's a mononuclear inflammatory infiltrate. So that's essentially lymphocytes and macrophages are seen. And the presence of macrophage it correlates with disease advancement. And as I mentioned, there are two kinds of macrophages. There's M1 macrophages. The M1 macrophages mostly release, again, inflammatory mediators, whereas M2 macrophages express what we call fibrotic genes. So they are important in triggering the fibrosis that happens. So essentially, this is innate immunity again, just like we talked about in the pneumocytes. And these lung macrophages, they have increased expression of pro-inflammatory cytokines that we mentioned again before, which is your IL-1 beta, IL-6, tumor necrosis factor. And they also release a lot of chemokines, because if you remember our basic cell information, it essentially tells chemokines are released, and that's how chemotaxis occurs, and they start to recruit more cells into the system. So going back to our old figure again, here is our M1 macrophage, here's M2 macrophage. M1 is responsible for edema, M2 for macrophages. Now all the stuff, chemokines that is released, is now starting recruiting other cells into the system here. Your CD4s, your other monocytes, NK cell all starts to float in, okay? So, so what are chemokines? And as I mentioned, they are like, another kind of cytokine, but has a very specific function. Most role is in recruiting cells. And this is a slide I came across, and it kind of talks about what kind of chemokines that you start seeing in an asymptomatic patient. Essentially, there is chemokines, but not to the same degree. The cells that you see are mostly, your monocytes out here. But when you start having symptoms, there are more chemokines starts to come into play. And here you start seeing your CL8, 10 different numbers. They don't really matter much. But essentially the key is you start to seeing more polymorphonucleosides starting to come in, your NK cells, your dendritic cells. And then as you move along, more symptoms, there are your T cells and B cells all come into play. So essentially just kind of say that chemokines, innate immunity is important in the hyperinflammatory response that we see. So the next group of cells that we are going to look at is your lymphocytes. So we kind of saw that lymphocyte count is decreased in these patients significantly. So when you look at it, the absolute lymphocyte count is a prognostic factor for severity and the morbidity. So both CD4s and CD8 positive T cells are decreased in these patients. But if you look at the lymphocytic infiltrate in the tissues, you actually see a CD4 T cell predominance. And why that is important, see now your adaptive immunity is coming to play, and they express again interferon gamma, IL-6, GM-CSF, a pro-inflammatory cytokine profile. So what is the cause for this decrease in the lymphocyte count? So they have seen in the spleen and the lymph nodes that there may be hemophagocytic macrophages. So these macrophages may be important in lymphocyte depletion. So essentially showing that the macrophages may have a role in the cause of the lymphopenia. They also have seen that T regulatory cells are decreased in these patients. So, and the peripheral NK cells maybe were decreased in these patients. So essentially there's a dysregulation in the T cell function. So the other group of cells that are again important, and we saw in our initial lab markers, there is an increase in the neutrophil count. How is that important? Because neutrophils are also, as we know, very important in controlling of infections, right? So they have seen that there is this neutrophil extracellular traps, or NETs, that are seen in these tissue biopsies and things like that they look at. And these are NETs, essentially webs of DNA materials, which has antimicrobials and enzymes. And that's how neutrophil control infection. But the NETs also, on the other hand, has a very disruptive effect also. So they can be very destructive also. So they have seen that there may be a role for NET and the platelets to interact with each other and resulting microthrombi formation. So because, we saw that strokes are very, it's a kind of a marker sometimes in young people. So microthrombi are very seen in a lot of these patients, and they're seen in their lungs, their hearts, their brains, their liver. And why do these microthrombi, how are they formed? That's because the endothelial cells have the ACE receptor expression. And so let's go back to our original slide, and I can briefly show that. So if you look in this slide, in the bottom part, in the endothelium, in the capillary, pulmonary capillary, you can see here the endothelial cells are expressing some of these ACE2 receptors, right? So that it may be playing a role in why these patients, and there are megakaryocytes are seen around there. And so now this all may be playing a role in the platelet fibrin clot formation out here. And I want to briefly touch on this side, which is the neutrophils, the monocyte, the NK cell, the TH cell, all, there's a lot of cell recruitment happens, and we kind of saw how all of these play together. So, in a summary, it kind of shows how the infection happens, and it drives itself forward, how innate immunity plays a role, and then starts to bring in your adaptive immunity and other players like neutrophils, your megakaryocyte, and how the symptom and the disease progresses. So this is kind of a summary slide, something that Rajesh talked about. And I think, there is lots of treatments, as he said, like multiple treatments in trials right now about how can you address this, how can you shut off the cytokine storm. But again, the problems we face is that we don't know exact sequence of when the chemokines come, which cytokines come, when should we shut them off? Because sometimes when these have multiple redundant pathways and they have other roles. So you kind of have to be very careful about when you use these medications and how you use them. So again, this is a summary slide and I won't spend a lot of time on it, but as you can see, the corticosteroids are very early. It does have a role both in the T cells, and it has a suppressive effect here on the acute phase responses. Also here, IL-6 kind of is important here, comes from the macrophages, and you have your IL-6 inhibitor playing here. JAK inhibitors have gotten some press recently. These are oral medications that has some role, and they can inhibit here at IL-6 level. They can inhibit here at interferon gamma, alpha beta levels. So there is different medications that are under play. There is against anti-IL-1 medication called anakinra. These are all repurposed medications from other diseases that have been used in these patients. But right now, as Sudhakaran mentioned, recovery trial, at least in the NIH guidelines, only corticosteroids, especially dexamethasone, has been found to have an effect on these patients. I just wanted to touch base on IL-6 because that is an anti-IL-6 is being used right now. It is a pro-inflammatory cytokine. It kind of has importance, a function on hepatocyte, and it induces a differentiation of immune cells like B cells and T cells. I threw this slide here, but it's already been discussed. But tocilizumab is a monoclonal antibody. It acts against both soluble and membrane-bound IL-6 receptor, and it decreases inflammatory markers like your C-reactive protein, ferritin, D-dimer. So you can use those markers to see if the patient is improving and there is oxygenation is improved in these patients. And it might improve survival, but it comes with a caveat, like Rajesh mentioned, there is increased risk of superinfections, especially in mechanically ventilated patients. And there is some concern if it's as effective as it is touted out to be. So that's, again, the debate. So I'll end up with this slide. It's all going to be okay. Any questions?
Okay, thank you, Sangeetha, for the nice presentation. Manish, could you please pass your comments?
It's excellent presentation from your side. It's excellent presentation. It's something new stuff for us, for me especially. See, see why all these things are occurring only in a pandemic situation, or you're having when if it is a new virus. Actually, in case of H1N1, You're not having it now, but during a pandemic you had it. Why is it not occurring now? That sort of cytokine storm and all. You're seeing it only in the pandemic.
Is it because? I mean, I'm
You got my question? You got my question?
I mean, I think the issue, no, I didn't understand your question. You're saying, why are we seeing cytokine storm only in a pandemic situation?
Yeah. Why see, the virus is there for a long time. You're getting such stuff, what to say, cytokine storm when there is a pandemic. Why it is not happening in the usual stage? When the infection gets endemic, why you're not getting such the.
So I think you kind of are confusing 2 points. Maybe I'm answering it wrong, but you know, the cytokine storm happens in multiple diseases. So, but the problem with this disease, I think, it is that it is a very contagious disease, right? So you are seeing a large population getting infected.
Okay, fine.
So maybe your incidence of cytokine storm is much higher. You're seeing it more common. I mean, or you feel it is very common. I mean, this disease has not been contained as much as other viral infections, like MERS or your SARS, other viruses, because the mortality rate was very high and the RO value for spreading was much less. So, this is a totally different mode of spread. So is the actual numbers higher? I'm not sure, but, and also the way this cell attacks, it's using an ACE type 2 receptor, which is a very ubiquitous way of getting into the cells. So it is able to attack, I think, multiple organs much easier than my other viruses. That's why I think it is, because look at the endothelium.
Sangeetha, why are you getting, so what you're saying is the inflammatory changes are occurring only in the lungs?
No, it is not occurring only in the lung. It is, if you look at the endothelium, has ACE2 receptor, receptor there. So if the first two can attach, it can form microthrombi in the endothelium, and that's why you're seeing that it's affecting multiple different organs, right? Different organs, right? So you are seeing that microthrombi in your lungs and your heart and your kidneys and other parts of the body too, not just in your lungs.
So what you're saying is the AC inhibitor receptors are there everywhere in the endothelium. Every
there
organ.
Is some upregulation. There is upregulation of endothelial receptors in the capillaries in these patients. So, that is the postulation why you're going to microthrombi. And you're seeing a lot of CD4 T cells also around these microthrombi. You're seeing megakaryocytes. You're seeing increased AC2 receptor expression on these along these endothelium. And so there is multiple factors in play. I think this is essentially a dysregulated innate immunity. Your innate immunity is supposed to protect you, right? I mean, that's how we fight off most infections before adaptive immunity comes into play. But here there's a dysregulation of the innate immunity, and there's a downregulation of your adaptive. That's why you're seeing less T regulatory cells, and you're seeing and NK cells are fatigued. So you're not seeing interferon gamma. So I think there's a imbalance between that. So that's what's happening, and all of this is postulation, right? I mean, this.
See, you were telling that cytokine storm is caused by a lot of mediators, but we are using only against IL-6.
That's exactly what I mean.
Why is it so?
They have used
because we don't have any drugs to counteract all the other inflammatory mediators.
There is IL-1. If you look at my slide there is. I'm going to slide one.
Can something like.
So if you look at in this slide, I'm going to from current slide. So I don't know. Okay, let me just.
But commonly we give only this one, no?
Yes, because they have, it is a more, they have used IL-1 right here, the anakinra, that's been used against, and that's used for other diseases, and they have used that in some studies. But the problem is this is like very broad spectrum. So you cannot, if you cut off one, you may be causing other side effects, which is not warranted, right? So you
Okay.
very careful. That's why I said there is a lot of studies coming out of this JAK inhibitor that is a baricitinib, which is an oral medication. There are studies because this can with IL-6, it can work. It's multiple sites of action. So they are using this medication. All of these medicines have been tried at different times, some of them not successful and have not made it into past any randomized controlled trials. But there is quite a bit of literature coming out of this particular medication. And this one we talked about, there was some studies on this one also. So they are using other.
But we only use this one.
Most people
Commonly we
use
use this one.
tocilizumab. Commonly, yeah,
Acha,
that's
acha,
what's
acha.
being used. Yes.
And you told that
Biju. We have to move on to the next session.
Yes.
okay, fine. One more question. We'll have it
Okay,
after
it's
this.
okay.
No,
Okay,
after
okay.
this. See, you told that, it is attacking the you told that all these receptors are present everywhere.
Yeah.
But why is it affecting the lungs first, not the other organs first?
Because that's how it is gaining entry into your body. Because
That is the reason,
right? Yeah, I think so. I mean, nasal,
okay, fine.
inhaling.
Okay.
It's,
No, okay, fine. Thank you. Thanks a lot.
no problem.
Biju, the answer to that question is the highest density of ACE2 receptors in the lung alveoli.
Yeah.
Okay.
That's the
compared to the other organs, huh?
Correct.
Yeah.
But
And
see, but in that case, Sudhakaran, in the case of multi-inflammatory syndrome, so what you see is there will be less of pulmonary symptoms compared to the other organ involvement. Why is it so then in that case?
No. The as I said, the highest density of the receptors are in the lung, but there are then there is receptors in the endothelium. There is in the cardiomyocytes, glia, gastroenterocytes. Now, everywhere there is. That's why you get those symptoms.
Yeah,
diarrhea,
I agree to that.
everything. Yeah.
But in case of multi-inflammatory syndrome in adults, especially the symptoms are, you don't get symptoms pertaining to respiratory tract. Why is it so?
It is no longer infectious. That's a problem. It's no longer
once you cross the threshold of this macrophage activation syndrome, then what happens is it goes to the picture of ARDS, which because of the lung, which is the main target here. So like all intensivists will know that after the ARDS is no longer an infection; it is inflammatory damage of the lung tissue. So that's the problem there. Once you switched on that macrophage activation syndrome, then it is very difficult to switch it off. The steroid is a general immunosuppressant. That's what the initial phase. Once that is steroid is a like a നമ്മുടെ broom പോലെ എല്ലാം അടിച്ചു മാറ്റും. That's steroid. But the other ones are more specific, like IL-1, IL-6, interferons. They are all more specific ones. JAK2 inhibitors. They have all got uses in other inflammatory disorders. So it's trying to switch off that. The inflammation once it is started. So that's where it is. So that's why they are trying all these various inflammatory anti-inflammatory drugs like IL-1 inhibitor, IL-6 inhibitor, JAK2 inhibitors. They all got some effect on, but they are not specific enough to treat the problem.
Yeah,
Okay,
and we
then.
don't know exact sequence of when to use what. That's
Correct. Yeah.
the thing, our
Yeah,
biggest
that's-
limitation. And, because these have broad spectrum roles and we don't know which, you don't want to shut off your innate immunity because the patient is able to clear. That's important, but we need to shut it off when it becomes dysregulated. So that's where.
So that's why you're not giving the steroids early.
Yes.
Is that
Yeah,
the
you
reason?
don't want to use the steroids early because you don't want to immunosuppress them. It's
Yeah,
only
okay, fine.
The point is, if you give it too early, what happens is, as Rajesh was saying, it will aid viral replication. But
Okay.
the problem is, you don't want to aid the viral replication, but you want to stop the inflammation post the viral replication, which is in the second phase of the illness, which is starting from day 5. So that's when people start feeling unwell with the respiratory symptoms, because by the first 4-5 days, you're really getting the infectious symptoms. The second, after the 5-6 days, what you're getting is the inflammatory problem, which is no longer it is no longer the viral multiplication. Viral multiplication becomes secondary, but it is your immunity against the viral multiplication which is causing the damage. So that's when the steroid comes into play. Okay. And
So
then
why not we give it so?
Sorry.
You can continue. So why not we continue?
Then the third phase comes in, where actually the steroid hasn't worked. Then you are going into the next phase of the inflammatory blockade, like IL-1, IL-6, and various things, to retrieve the organ damage. So this is a very simplistic view. That's the first phase is viral multiplication. Second phase is the inflammation, the early inflammation, where the steroids may be helpful. The third phase is the inflammation, which is uncontrolled. Now it's caused multi-organ failure. Then you are just trying to retrieve it. Okay.
Okay,
so in the case of multi-organ failure also, you give the same dose of steroids, or is it higher?
Because once it is the steroids, after that amount of dose, or 5 days of dose, even if you give it for many number of days, it is not evidence proven that is changing anything. That means it is like the horses are bolted out now of the stable, and then you're trying to close the door. It is done already, the damage. Sorry.
Okay, thank you.
Okay, so we are moving to the last session of the day. That is by Ashraf, and Ashraf will be talking on anticoagulant.
All right, so let's see if I could share my screen.
Okay.
All right. Can you see?
Okay.
Can you see my slides?
Yeah.
Can you all hear?
Yeah, can.
Okay.
Yes,
all right.
yes.
So when Biju asked me to talk, I was pretty, easy, early to accept, because I had done the same talk, but 6-7 months ago for AKMG, and I thought I could use the same slide deck. But when I looked up, the data, the whole thing has changed. So I only have the first 2-3 slides as the old one. Everything else has changed. I have no disclosures other than the 10 Bitcoins Biju has sent me. Thank you, Biju. But no other disclosures. We had, very good review by, Biju on the home quarantine. Rajesh did an excellent job, and Sangeetha, of course, really explained the pathology very well, which kind of helps me also, because some of the things are, similar in coagulation also. All right, so since kind of late in India, I'm going to go through it without, spending a lot of time on individual slides. But basically, the COVID associated coagulopathy is an entity all by its own. It doesn't really fit with our standard coagulopathy that we have, the substance-induced coagulopathy.
Ashraf,
can you hear me?
Yeah, I can hear you. Why can't you do a slide sharing, slide presentation?
Oh, I'm not slide present. Oh, I'm sorry. Okay, sorry. I thought I already did. Can you see? Can you see now? Mm-hmm. It's better.
No, yeah, it is okay now. It's fine.
Okay. All right. So COVID-associated coagulopathy, from the very beginning, it was reported from China actually that there was an increased incidence of coagulopathy in these patients, and this COVID-associated coagulopathy is a different, a completely unique entity in hematology. It doesn't really fit with DIC or success-induced coagulopathy. It is different from the hemophagocytic syndrome. It is different from antiphospholipid syndrome, and it is different from the HCS-TTP or the thrombotic microangiopathy. But it does have features of all this other, coagulopathy also. But COVID coagulopathy is quite unique in that you see, I'll explain some of the labs down the line. Sometimes you can have, the same patient with COVID can also have DIC, even though it's kind of rare and very terminal stage. They can rarely have TMA or HCS-TTP. And very rarely they can have antiphospholipid, not the syndrome, but they can develop antiphospholipid. The only thing, if they do have that, it's important to note that they may have a high PTT, which doesn't necessarily mean they are going to have bleeding. They tend to have more clotting problem. And hemophagocytic syndrome, again, activation of phagocytes are seen in these cases, and sometimes it can develop this, syndrome where you have very high ferritin, and so this Venn diagram kind of shows you, there are most patients have just COVID-associated coagulopathy, but some patients may have additional coagulation abnormalities also. And if you have if you have complicated coagulation patient in an inpatient setting, it is not unreasonable to ask a hematologist to look at it. All right, so as you can see, the risk of VT in hospitalized COVID patients, is very high. It ranges from, in ICU setting as high as 47%. And the harder you look, like, the more Dopplers and more PE, CT angiograms you do, the more you see that. And non-ICU patients also, it is fairly high compared to a non-COVID patient, up to 6 to 7%. So it's a fairly common problem in COVID. And the pathophysiology, I'm going to go through it very quickly because Sangi explained a lot of it in excellent detail. Just to add the fact that ACE2, what ACE2 does is it converts angiotensin 2 to angiotensin 1 through 7. And that's a good thing because angiotensin 1 through 7 actually increase the nitric oxide, and it's also vasodilate. So that is what angiotensin 2 does. So when the ACE2 get blocked by the virus and the ACE2, the ACE2 doesn't work, the angiotensin 2 accumulates, and that is actually a vasoconstrictor, and it also causes some other damages. And the endothelial damage that was mentioned in Sangi, that's a very critical part because endothelium is very rich in ACE2. So what happens is there is this so-called Weibel palade body, and that get exposed, they releases von Willebrand factor, and that is, along with the complement pathway get activated. So the whole Virchow triad, you get the endothelial damage, there is, patient is, bedridden. I mean, this is talking about inpatients. And also hypoxia is also a cause for worsening hypercoagulability. Hypoxia, as some of you may remember, decreases protein S level, and protein S is actually important as an anticoagulant. It's a natural anticoagulant. One interesting thing with COVID-associated coagulopathy is that it is, the elevation of, okay, this is a picture of endothelitis, that is kind of a late stage, but you can have endothelitis from the very beginning. And endothelitis is when you have vascular injury, and vascular injury is one of the biggest initial event for the coagulation cascade to start. The tissue factor, whenever there is endothelial injury, the body assumes, you have a cut or an injury, and one of the body's natural reaction is to activate the coagulation pathway. So COVID-19 associated with hemostatic abnormalities, or it's CAHA. By the way, there are like over 1,200 papers in the PubMed on all these things. This is why I was thinking in COVID, in 9 months in COVID is like 9 years, because I had to remove all my prior slide from 6-7 months ago and make all these new ones. Anyway, COVID associated hemostatic abnormalities is short-term is CAHA. They also have 3 stages, as you can see here, the stage 1, 2, and 3, and they follows the usual COVID staging also. So in stage 1, you have D-dimer that is up to 2-3, maximum 2 to 3 times normal, whereas stage 2 is 3 to 6 times, and stage 3 more than 6 times normal. The platelet count is mostly normal in stage 1. PTT is usually normal. The fibrinogen is often increased, and the DIC picture, that is decreased fibrinogen, that's often rare, and the plasminogen activity is often increased. Okay, now that is stage 1, whereas in stage 2 you can actually have some mild thrombocytopenia can happen, and the PT. This is important. This is a very common, simple test to do. A slightly prolonged PT actually is concerning in a COVID patient. And in stage 3, you can have marked prolongation of PT. The PTT prolongation is rare, and that is, unless they have an antiphospholipid. Any virus can cause a transient antiphospholipid antibody presentation, and that when you have PTT elevation, it's often that. And if you want to be 100% sure it's not a true deficiency, you can do a so-called mixing study that will show the PTT in a mixing study differentiate like a deficiency versus an antiphospholipid antibody syndrome. One of the interesting thing about COVID-associated coagulopathy compared to say DIC and all, in the late stages, you actually have relative deficiency of plasminogen. Now, what is D-dimer is actually a product of both increased coagulation and increased fibrinolysis. So this sounds kind of counterintuitive. So how do you have decreased plasminogen while the D-dimer keeps going up? Because for the D-dimer to go up, you need to have not only coagulation, you also have destruction of the fibrin, the fibrin product. So for that, you have to have a fibrinolysis should be active. But what you find is fibrinolysis is actually suppressed in late stages of COVID-associated coagulopathy. And this is interestingly due to, or the most likely explanation is there is something called urokinase, U plasminogen activator. It's called UTPA. You all have heard of TPA, which is the tissue plasminogen activator. But there is an entity called urokinase plasminogen activator, which can do some fibrinolysis, and that is secreted from the alveoli. And alveolar damage can increase the UTPA levels, and that is why you can have this kind of counterintuitive process of decreased fibrinolysis and increased D-dimer in late stages. And this is unique for CAHA, because you don't see that in say DIC and all. In DIC and all, you have elevated D-dimer, but not the kind of elevation you see in COVID. Now, of course, you can have non-venous thrombosis in COVID also, including ischemic strokes, myocardial infarction, acute coronary syndromes, any kind of extracorporeal circuits like hemodialysis catheter. The blockage is up to 8 to 10% reported. Mesenteric ischemia, leg ischemia, all this has been reported. And also this large number of microvascular thrombosis can happen in kidney and lung, even that can be missed on imaging studies, as there are seen in some autopsy series. A large number of sick patients tend to have microthrombosis. Now, this is a hematological abnormalities that you usually see in these patients. So the one that is highlighted in the red, those were the things that were, found to be associated in survivors versus non-survivors. So elevated PT, and as you look at the number, the PT in the survivors was median was 13.6, and the non-survivors was 15.5. So it's not a marked increase, but it was interesting to note that difference. And of course, D-dimer, you can see that was a big difference between the survivors and non-survivors. And as Sudharan already mentioned, I agree with you. A D-dimer actually is probably one of the single blood tests that's probably one of the most predictive of mortality and survival. And you can also see increased FTP or fibrin degradation product in the non-survivors. The first report of this significance of D-dimer was reported from China. This is a much quoted paper that showed like the big curve difference between the survivor and non-survivor in terms of the D-dimer numbers. You can see that patients who have more than 1 microgram per ml, their survival was markedly reduced. Now, in terms of anticoagulation, this is a big, controversial topic. So, so some of the questions we will try to answer, should all patients to be getting prophylaxis? What is the intensity we should use? What about the post-discharge prophylaxis? Any biomarkers, how to use that, and thrombolytic therapy in select patients. So this is a kind of a summary slide, and this is kind of updated recently. And I had to, retype some of these things because this is not how it was in 2020. So ICU, all patients require thromboprophylaxis unless contraindicated. And Rajesh already mentioned that, and I totally agree. Now, intermediate dose thromboprophylaxis is not to be used widely outside of a clinical trial. However, if you have an obese patient, say over 120 kilogram or BMI more than 35, they should have Lovenox 40 twice daily. Now, this last sentence may kind of come as a surprise. I have a couple of slides down, down to say why that is. No role for therapeutic dose anticoagulation in the absence of documented VTE in ICU patients. And this is different than what I myself had on my slide 6-7 months ago, but again, that's shows that how much the data, how fast the data is changing in COVID. In non-ICU medical patients, you should put them on low molecular weight heparin. And again, it's low molecular weight heparin is the best anticoagulant for prophylaxis. One, very little drug interaction. And unlike heparin, very little interaction between the nursing. Heparin is a complicated drug. You have to keep going into the room and do PTT and all those things. So the standard of care is low molecular weight heparin, unless the patient has severe renal injury. Surgical patients, of course, need to be on prophylaxis if they have COVID. In terms of OBG patients, I know I saw Rosia's face there. So low molecular weight heparin, if delivery is not expected within 24 hours, and after delivery, and it should, if you are planning a kind of epidural or cesarean, you may want to switch to unfractionated, the old type heparin. The advantage of the old heparin is it is very, very short acting. You stop it and within 2 hours, it's out of your system. Whereas low molecular weight, you have to wait about 12 hours. All right, so in terms of full dose anticoagulation, okay, now I hope nobody leaves right now, because if someone leaves, then they will be thinking this sounds great, but this is just to show that this appeared like a great idea. We know that COVID has a hypercoagulable condition. There was some interesting data from all over, including from US, that showed patients' survival improved when they were given therapeutic dose anticoagulation. So the question was, we know there is a very high risk of breakthrough clotting even with prophylactic anticoagulation. We know that patients in the ICU had a high risk of VTE. So why not put them on full dose anticoagulation unless there is a problem? And what it did find, this was a single institution kind of a simple study, but it did show that the survival was better when they got full dose anticoagulation. Okay. However, this is where, this is exactly where how data changes, so this is the randomized control trial. This is still ongoing, by the way. So this is called a multi-platform RCT. This is multiple countries and multiple continents. And it has been kind of coordinated so that we will have a larger data. And what it did show is that what the primary endpoint was 21 organ support-free days, as defined by the number of days the patient is alive and free of organ support through the first 21 days after trial entry. Key secondary endpoints was endpoint of death, P, systemic arterial thromboembolism, myocardial infarction, ischemic stroke, or at 28 days of enrollment. As far as I know, this is the only randomized trial of a blood thinner where the endpoint, primary endpoint is not clotting. The primary endpoint is organs, 21-day organ support-free days. Because in a pandemic situation, I think that is more important. You probably would prevent maybe less, you might prevent a little bit less PE, but what is more important is, are you making that any meaningful, is it really meaningful for the patient? Are the patient less on ventilator, less on dialysis, on dialysis or less dead? And this had to be stopped in terms of therapeutic anticoagulation arm was prematurely stopped. Someone has to be muting. Anyway, so this has to be stopped prematurely because in patients in severe disease who were getting therapeutic anticoagulation, there were no improvement, and in fact there was a, sorry, let's
Suresh on the mute.
I can't find Suresh, but anyway, so the contrary, this was quite a surprise and kind of unexpected.
Ashraf, you can mute all of them.
Yeah, I'm muted, Suresh. Yeah, can you all see me now? Hear me now? Okay. I may want to make sure I didn't mute myself. All right, so the expectation was in severe disease, you put the patients on therapeutic anticoagulation, they would be better off. However, in terms of the outcome measure, which is, as I mentioned, is 21-day organ support-free days. That is the most critical endpoint that was looked at. There was really no difference. In fact, therapeutic anticoagulation, if at all, was slightly worse in terms of mortality. So this multi-platform RCT stopped therapeutic anticoagulation in severe patients who are in the ICU. Again, COVID is such a surprise. This is exactly opposite to what everybody thought would be the outcome. But what was even more surprising was in moderate disease, therapeutic anticoagulation did have a benefit. Okay, so therapeutic dose study altered for enrollment for severely ill patients due to futility. Whereas full dose anticoagulation was superior to prophylaxis in reducing the need for organ support and mortality in moderately ill COVID in hospitalized patients. Okay, this data is kind of brand new to such an extent that it is not part of any of the recommendations. So none of the organization recommend therapeutic anticoagulation in moderate disease, but I'm fairly certain the updated recommendation maybe 3 months from now, we might be doing therapeutic anticoagulation in select group of moderate patients before they go to ICU. And the explanation why this was the way it is probably because in severe illness, it was too late for anticoagulant to reverse the horse has left the barn, as Sudhararan appropriately mentioned. So severe disease, it may be too late, whereas moderate disease is where you may be able to make a difference by actual therapeutic anticoagulation. Again, I'm just showing it to you all here, but this is not part of the guideline. I'll show you the guideline in a minute. Okay.
Ashraf, can I? It is part of the UK guidelines now.
It is part of the UK. Oh wow, that's great. Okay.
Yeah,
UK,
from from April onwards, this is part of UK guidelines. Yeah.
That's great. That's great. Okay, because that's great because, in fact, that does make sense to do moderate disease therapeutic anticoagulation. I'm glad I didn't know that, Sudhararan, because none of the guidelines I looked at. This is the guidelines, the latest guideline that from different ACC, American College of Cardiology, American Society of Hematology.
It is not in the other guidelines. It is just the UK guidelines. Yes.
Yeah, that's great.
That's correct.
And I'm fairly sure all these guidelines will get updated because I think these people met before the interim results were out. So this is the kind of summary slide. You may want to spend some time looking at it. It's very similar across the guidelines. Again, say prophylactic in all except UK, which I don't have, which I'm glad Sudharan mentioned that. So the guideline is prophylactic dose as of now, but again, like I said, the data suggests therapeutic anticoagulation is a reasonable thing to do in moderate disease. ICU patients, again, prophylactic in all. ISTS does say intermediate in select group. Prophylactic do include higher dose of Lovenox in heavy patients who are 125 kilogram or more. Post-discharge thromboprophylaxis, only ISTs has a specific guideline about it, and in patients who meet a certain criteria in terms of the improved score or improved score more than 4. Improved score is like you can look at MedCalc or it's basically anybody over 60 get an improved score of 2 automatically. If you have improved score of 2 and a D-dimer that is elevated, that is an indication for outpatient prophylaxis. Improved score of 4, irrespective of D-dimer, is an indication for outpatient prophylaxis. VTE treatment, again, standard treatment, and the length of treatment, standard recommendation is 3 months. So therapeutic anticoagulation, of course,
Ashraf, I have a doubt.
Yes. Yeah.
Ashraf, how do you make out that the patient is having moderate disease? What is the criteria?
The standard COVID criteria.
That is used in India, the same one?
In which setting are we talking?
No, you told that the therapeutic dose of anticoagulants is given in moderate severe patients.
Yeah. That is I need to double confirm whether the Indian guideline is any different. But the mild, moderate, severe is probably across the world is pretty much similar. Maybe there might be slight difference. Yeah.
Okay.
All right. So this is therapeutic anticoagulation. Of course, if you have document PE or DVT, is fairly simple decision. But sometime if you may have to do transthoracic echo if you have a clot, that's great. Now some cases where you may have to start this patient, say sudden decline in respiratory status with a sudden increase in D-dimer, and no other explanation like no acute MI, the chest X-ray doesn't, no significant marker change. So if you have a very high clinical suspicion of a PE and you can't do a CT angiogram, that may be an indication for therapeutic anticoagulation in an ICU setting. That's unexplained respiratory failure or any physical finding of thrombosis, of course, and clotting of intravascular access device, whether it's for ECMO or hemodialysis catheter, you can see that is very common. I think it's 8 to 10% is reported. TPA, again, very rarely used, but if you have a limb-threatening DVT or massive PE, acute stroke, acute MI, in the right setting, you can use TPA, but not a usual standard of care. In terms of post-discharge, at least in the US, these are the 2 drugs that are mentioned, but of course you can use any factor Xa direct inhibitor. The one that is commonly used is rivaroxaban or Xarelto as 10 milligram for up to 39 days. There's another one called betrixaban. Apixaban is another safe drug. It's 2.5 BID, even though that's not in the FDA specific approval. Inclusion criteria for the trials, this was the one I mentioned. Modified improved VT score more than 4, or modified improved VT score more than 2, and D-dimer more than 2 times upper limit of normal. Okay. Now, this is why post-discharge thromboprophylaxis is important. That post-discharge, you can have patients who are discharged still have about a VT rate of about 1.55%. So that's why in select group you don't do it in every patient, but in select group of patients they may need to have post-discharge thromboprophylaxis. A quick slide on the bleeding aspect. These patients actually, especially towards the end, are also at high risk of bleeding. They do have features of DIC in rare cases. So if they have associated bleeding, you have to give them, platelets. If the platelets are less than 50,000, plasma if the INR is more than 1.8, fibrinogen concentrate or cryo. If the fibrinogen is decreased, again, this is in severe disease only you see this. And patients with severe coagulopathy and bleeding due to liver dysfunction, you may have to give them the prothrombin complex concentrate. Okay. The other agents like the TXA and all is not well studied in these patients. So kind of a brief summary: hospitalized patients with COVID-19 should be treated with prophylaxis unless contraindicated. Parenteral anticoagulation therapy is suggested at standard doses, with the caveat that may change. In the moderately ill patients, they may need therapeutic dose. Multiple advantages of low molecular weight heparin because of less drug interaction, high rates of thrombus and death in post-discharge COVID-19 patients, and can be reduced by thromboprophylaxis, mostly with the oral anticoagulants, like the newer direct oral anticoagulants. And patients with conformity treated in the standard way for 3 months. Now the data is evolving, and the guidelines may get updated, and as UK has already done, our guidelines have not yet updated, but I expect it will get updated very soon. COVID is such a moving target, and again, one of the really confusing disease. So like I said, the RCT outcome of increased mortality in severe patients on full dose anticoagulation was a complete shocker. Again, I think that's the end of my slide, and thank you so much. Appreciate all of you listening and staying awake this late, and happy to discuss anything. And I think we can have a common discussion, and really there are no experts here. We all learning, so there are people all here are kind of experts. So please, share your experience, questions or your own thoughts. I think we should keep it open to everybody. Thank you all.
Thank you, Ashraf. That was a very good presentation. Biju, when he presented, he said in the home isolation recommendation with the DOAC.
Yeah.
So I was carefully listening to your data where you will say that, and I didn't hear it.
Yeah. I mean, there's unfortunately there data-free zone. Now the only data is in post-discharge patients that you can extrapolate. So if you extrapolate the post-discharge patient, in terms of home isolation, I think it's not unreasonable. But again, like I said, this is all, there is no high-level data in any of this recommendation. Whether it is a reasonable thing to do, I personally think it is in the select group of patients. But again, understand that things that we thought were sensible, like I said, full dose anticoagulation in ICU setting sounded like the most rational thing to do, but turned out didn't work. So so there are things that there are data for, and then there are things where you go by rational decision. So I think patients who are sick and cannot come to the hospital, I think it is reasonable, but again, we need to realize it's not based on a lot of data.
Ashraf.
Yeah.
Can you hear me?
Yeah, I can hear you.
Yeah. What is the real indication for starting anticoagulant? Is it the dyspnea that is? Yes. No. Prophylactic.
Oh yeah. I mean,
therapeutic means only. No. Therapeutic we can only give for 2 indications. No, as per the Indian guidelines.
Right. Hospitalized patients. Hospitalized patients. Everybody should be on prophylaxis. Now, are you talking about? Yeah, hospitalized patients. Every hospitalized patient should be on anticoagulation, unless there is an active contraindication.
Can I make a comment there, please?
Yeah, please.
On the anticoagulation, the anticoagulation rate, as Ashraf mentioned, in US, in Western countries, probably every patient who is admitted to the hospital will be on thromboprophylaxis. The incidence of VTE is 1 in 1,000. So everybody will get anticoagulation if they are in the hospital and they immobilized for more than 72 hours. So that means if you day care surgery or day unit, they don't need anticoagulation. So everybody will get prophylactic anticoagulation. The question here was about the intensity of anticoagulation, whether they can make any difference or not. And surprise, surprise, as I said, the moderate ones, which are going to the ICU type of patients, still seem to have benefited from it. That's why the guidelines were changed. And the anticoagulation prior to admission, which is their home scenario, I have not heard about it here. They don't do it either. So I don't know where the data is coming from. And the other thing, which is an observation, generally, in Indian population, the amount of spontaneous thrombosis is probably less than Western, according to some of the data. It's because of the increased incidence of factor V Leiden mutation, which is there in the Caucasian population, unlike us.
Yep.
So I'm not sure whether pre-admission anticoagulation is actually needed. I don't know, for even in COVID situation. I have no idea. That's my comment.
Yeah. Yeah.
Ashraf? See,
it's
Ashraf?
a little tricky. Yeah. Yes, Biju, I can hear you.
Yeah. See, according to the Indian guidelines, what they're saying is if the rivaroxaban or apixaban is not available, they are even recommending aspirin.
Yeah, again, like I said, DMC or data makeup zone. So like I said, I mean, if as long as things are not totally unreasonable, I guess it's reasonable. But again, most of the clotting issues is unless it is arterial, here it is mostly a venous kind of issue. Antiplatelets doesn't really work. I mean, of course, it's definitely better than probably nothing if you have a high risk patient, but and if the patient can't afford or something. But antiplatelets, it's not primarily platelet mediated. It is a clotting factor mediated problem. Unless, of course, this patient can have ACS and all, acute coronary syndrome, but that's a different arterial issue. But most of the venous issues we see are actually from the clotting, clotting related, and the clotting pathway itself, there is very little you can do, with aspirin.
Ashraf, could you
one point. Excuse me, one point. You said it is abnormal accumulation of angiotensin 2.
Yeah.
Hello?
Yes. Yeah.
Angiotensin 2. Abnormal accumulation of angiotensin 2 is there.
No.
Yeah. Yes, angiotensin 2 and decreased amount of angiotensin 1 and 7. And 1 and 7 actually is vasodilator and increases nitric oxide.
Okay. Angiotensin 2 is a vasoconstrictor.
Angiotensin 2 is a vasoconstrictor, and the angiotensin 2 accumulates. Right. Because of ACE2 is blocked. The converting enzyme is blocked.
Yes.
The angiotensin 2.
It looks like a pregnancy-induced hypertension. Here there is abnormal sensitivity for the vessels to the angiotensin. In that case, we are using aspirin as a prophylaxis. So it may work in the initial stages before your clotting cascade is activated.
Yeah, it may. But again, these are all simultaneously happening. It's we learn all this in kind of in serial, like one after another. But in reality, unfortunately, multiple things are going wrong at the same time. But I mean, again, I don't have. I don't think it's wrong to do, but it's reasonable. Yeah. Yes. Yeah.
Ashraf, can you hear me?
Yeah. I can hear it.
Patient on heparin while in the hospital. At the time of discharge, switching over to work. So is there any overlap required?
Yeah, I'm so cut type. Patient on heparin in the hospital.
While in the hospital.
Yeah.
While in the hospital, patient was on heparin. Now the patient is being discharged.
Yeah.
So I want to start him on or her on the work.
Okay. Yeah. So yeah, this is
overlapping required.
No overlap. Okay, so this is okay. Now with heparin and warfarin, you always need overlap, right? Because for one thing, warfarin doesn't work immediately, and for that 3-4 days until the INR is therapeutic, you need to give them heparin and warfarin. The other reason is warfarin decreases your protein C and protein S before it start becoming an anticoagulant. So warfarin actually is a procoagulant. So if you give somebody with a blood clot warfarin without heparin coverage, things are actually going to get worse. However, the good thing about DOAC is you can straight switch to DOAC. So you stop the heparin like Ulovinox. There is no overlap at all required.
Okay, that is thank you.
Yeah.
So any more question? It is already late.
Ashraf, did you notice any increase in RBC count in post-COVID patients?
I'm sorry. Did I notice what? RBC what?
Rise in RBC count, polycythemia in any patient.
Oh, well, no, I have not, but you can have increased viscosity in these patients, mostly from polyclonal hypergammaglobulinemia, because the patient is, see, the thing is, somebody or Biju or someone asked, what is wrong with this COVID compared to other viruses? I mean, the main issue is our body and our immune system is completely, taken by surprise by this virus. Virus is thinking this is something from some alien planet. And the body is thinking, and what body does when you are attacked by something it doesn't know what to do is throw the kitchen sink at it. The kitchen sink of our immune system, kitchen sink of our coagulation cascade. By the way, coagulation and immune system, they are so closely related. There's a term actually called thromboinflammation. And this is a term that has been getting popular even before COVID. We are realizing a lot of chronic disease, including things like Alzheimer's and all. There might be a lot of underlying thromboinflammation as the basic pathology. Thing like the NET that Sangeetha was talking about, those things that increases. NET is one of those bridging thing. When you have inflammation, the NET get released, and the NET activate the coagulation cascade. So the inflammation and coagulation, they are kind of goes hand in hand. They are like. And together, acute and chronic, they cause all these kind of problems. So with COVID, I think the problem is the body doesn't know what to do. And 80% of the immune system know exactly what to do, get rid of it, done. 20% is where, the immune system doesn't know what to do. They go into this, haywire, throw the kitchen sink at the problem, and, goes into this kind of a vicious cycle of, coagulation, inflammation, ARDS and whatnot. But I have not seen increased RBC, but I have not seen that. Is that something you have seen? I am not familiar. So Dagar may have seen some, I don't know.
Yeah, Ashraf, before that, just at that point, Vijay here.
Yes, Vijay.
Yeah. We have been seeing many patients with very severe headache. The only presenting symptom is severe headache, paracoccipital, frontotemporal, without significance. There is no features or raised ICT, no focal deficits. But on evaluation, we have seen some more like a venous infarct with hemorrhage, like picture in the cortical, subcortical level. Sometimes some small sulcal hemorrhages that has been seen at least in 4 or 5 patients in the emergency department. And as you mentioned, the thromboinflammation is one of the issue is here also. And many patients are in the periphery now without getting intensive care. We have seen certain patients who are admitted in the COVID ICU developing stroke while in hospital. At the same time, those who have got propensity to develop such slightly gradually increase in D-dimer, what can we do in the periphery to advise physician like which anticoagulant would you suggest so that we can advise some? They may not get a bed in the ICU. For example, we had no bed today in our hospital. 60 ICU beds are full and 17 ventilators are full. So I had to turn to at least 3 patients today. So in a patient who is sitting in the periphery, like say in the Vadagara Cooperative Hospital, say somewhere the Kotak and all, if patient progressively increase in D-dimer, which anticoagulant would you advise so that without much monitoring, they can advise? Because many physicians are afraid of giving oral anticoagulant for want of monitoring. What is your opinion?
That's a very legitimate and practical question. So yeah, if you are in a situation where you would have admitted the patient, but the patient is not in the hospital, I would consider that a hospitalized patient. It is just a practical aspect. The patient is hospitalized, but you are not in the hospital. So in a situation like that, my personal preference would be apixaban. I probably wouldn't do, therapeutic as an outpatient, but 2.5 milligram twice daily. The advantage of apixaban is it is, well tolerated. It doesn't get excreted through the kidneys as much as others. So, renal injury is not as much of a problem as, say, rivaroxaban. And because of the twice daily dosing, the pharmacokinetics of apixaban is actually a little bit better. You have a reasonably steady state anticoagulant activity as an outpatient. The only thing to remember, especially since Pradeep asked this question, or Pradeep or Gafur, I would have said, the drugs are very difficult to give in patients who are on like CYP3 inducers, and all of the anti-seizure medications are. So if the patient is on anti-seizure medicine, it is very difficult because you don't know whether the patient is getting any benefit. So if the patient is on a CYP3 inducers, as most anti-seizure medications are, you may, unfortunately, the only drug in that situation is actually the good old warfarin. The problem with the warfarin is that, like I said, it is hard to do warfarin alone in a hypercoagulable condition without covering with heparin, because warfarin reduces your protein C and protein S levels. But if you have a situation like that where you can't give a DOAC, you may have to do that. You have to give them low molecular weight heparin until the INR is therapeutic. But again, those patients are very hard to manage as an outpatient, to be honest. But in terms of outpatient DOAC, my personal preference is apixaban. Sudharan is here too. I think if he's still here, I don't know if he has some other, different opinion.
No, apixaban is easy to give. So that, compared to rivaroxaban and other things, it has less renal excretion. So that's good. Generally, it is preferable over warfarin because you don't have to monitor it. You just have to give it.
Yeah.
But your point of interaction with the CYP3 is well taken. So it is.
Actually, Ashraf, the Kerala guidelines, they are recommending rivaroxaban 10 mg daily and apixaban 5 mg BD for 14 days.
Okay, that is a treatment dose. Again, like I said, it's probably okay, but again, remember that is a real treatment dose, and as long as the patients, at least you have a CBC and platelets and all, it is very, very safe. The actual number of bleeds on even treatment doses of apixaban is very rare. But remember that that is not equivalent. 5 BID of apixaban and 10 of Xarelto, they are not equivalent. 10 of Xarelto is 10 of Xarelto or rivaroxaban is equal to 2.5 BID of, because they are both kind of long-term prophylactic dose. So 5 BID of apixaban, the equivalent dose of rivaroxaban is actually 20 of rivaroxaban. So 2.5 BID. So 2.5 BID apixaban is a prophylactic dose, or there's a trial called Amplify Extend, where patients who had a blood clot, they got apixaban 5 BID, and then after 6 months they were put on 2.5 BID as a prophylaxis dose, and they found there were less number of DVT. The same trial was done by rivaroxaban using 10 milligram once daily, right? So this recommendation doesn't make internal coherence. Do you see what I'm trying to say? Rivaroxaban dose is 10 once daily, should be equivalent to apixaban 2.5 BID, because they are the equivalent, dosing in terms of indications.
Biju, is it 10 milligram, 5 milligram BID of apixaban recommended in our guidelines?
Let me just check it. Just check it.
I think it is 2.5 BD.
No, let me see it.
Yeah. Again, one quick point about antiplatelets. Things. Some of these patients who has to be on like antiplatelets also. Remember, most of them have significant interaction with antivirals. So again, drug interactions. Something to think of, especially like antiplatelet like tigecycline. So usually a cardiologist use it as a major interaction with remdesivir. So this is something to keep in mind.
Just a minute, I'll share it once again, okay? I'll share that slide. Just a minute.
My memory from VT treatment is 5 milligram BD apixaban to start off, and prophylaxis 2.5 BD. Apixaban 2.5 milligram BD is a considered prophylactic dose. Rivaroxaban, the rivaroxaban,
you can see the recommendation.
Correct. Yeah. Yeah. No. It is in the recommendation. Yes, that's correct.
Yeah. This is the recommendation.
Yeah. No. The point was,
That's, I mean, it's not under, what I'm trying to say is, rivaroxaban dosing, if you are giving rivaroxaban 10, why are you giving, apixaban 5 BID? That doesn't make sense. But I mean, that's okay. I guess that's okay. It's not a big deal, but.
Ashraf, should we reduce the dose of anticoagulants in case of those who are on antiplatelets and clopidogrel, those patients?
Yeah,
already on antis.
Yeah. I mean, of course. Yeah. I mean, that clearly increases the risk of bleeding, but that is done all the time. Most of the.
So what should we monitor? Which biomedical parameters will that?
I mean, if you are doing it only for 2 weeks, I probably wouldn't worry too much. Unless. But if you are, if you're talking in general, if you are a patient who is on this for long term, like for AFib and coronary artery disease, I mean that's a common combination you see. I mean, you have to monitor their, CBC and iron levels at least every 2-3 months. I'm not talking in terms of COVID, in terms of patients who are on antiplatelets and and their DOAC. They, especially older folks, they become severely iron deficient. We see that all the time. I've seen patients. I don't know if there are any cardiologists still logged in, but I see patients, getting the correct dose going up and up, patient complaining of shortness of breath, but the patient never got a CBC done until they got admitted to the hospital, so sometimes the cardiologists forget the main function of the blood is, the heart is to pump blood. So if the patient is on all kind of blood thinners, they need to have the CBC and iron monitored frequently.
Okay, Biju.
All right, I guess we should end it, or?
Yeah. It's already late. It's going to be 11 here.
All right.
Yeah.
Shall we wind up this?
Yeah.
The 4 already right across.
Good job.
Special thanks to
Biju and Ashraf and Sangi and Rajesh and everybody.
എനിക്ക് പറഞ്ഞില്ല എൻ്റെ പേര്
ഞാൻ പറഞ്ഞു ആദ്യം പറഞ്ഞു
Biju, you are the man.
Yeah, you organized this. Coordinated this.
Yeah, and Rajesh, that is an excellent review, and Sangeet,
Yes,
that is
it
awesome.
was.
Thank you.
It was. It was. Thank you. It was very useful.
Thank you all. Thank you, Sangeetha. Thank you. Thank you, Ashraf.
Bye.
Thank you, Rajesh. Thank you, myself.
Thank you.
Bye-bye. Good night.